Hi, everyone, and welcome to our webinar for our Northeastern states for our AL amyloidosis patients. All our previous webinars can be seen on our website on the amyloidosissupport.org under webinar link, and also on our YouTube channel. If you haven't gone to our YouTube channel, it's very exciting, and I hope you go there and sign up as soon as you can. Okay. When you this webinar should be available in 2 weeks, so don't email me about it for 2 weeks, and then you can ask me where is it. Okay, we hope to be able to resume our live meetings again sometime in 2022. We don't know when, but until then, if you miss that personal contact with other patients, be sure and join our Facebook group for AL amyloidosis. It is a private, closed group. I know some people have issues about Facebook, but this is a very closed group. It's a monitored group, and we take very good care of all the patients and caregivers that are on there. You won't be able to post questions today in the Q&A. I mean, you will be able to post questions in the Q&A. You won't be able to have access to the chat. Paula and Bob will be putting some important things in the chat link for you. In the control room today, we have ASG's Executive Director, Paula Schmitt.
Hi.
And our Special Projects Director, Bob Gibson.
Welcome, everybody.
Okay. Our esteemed panelists today are hematologist Dr. Heather Landau from Memorial, Sloan, Kettering in New York, and Dr. Cara Rosenbaum from Weill, Cornell in New York, and Dr. Suzanne Lentzsch from Columbia. It's an all New York group today. We did invite other doctors from other states, and they may be popping in. Everyone seemed to have a conflict today, but we may have some doctors popping in, and we'll let you know when they do. Okay, there'll be a short survey to take when the webinar is over, and we ask all of you to take part in that. It's really important. It helps us develop new webinars. We do read everything that you say. Okay, we'll be working off our treatment chart today. Bob will put it up there for you to see. There it is. Okay. And you can, if you want a copy of our treatment chart, you can feel free to email me at muriel@amyloidosissupport.org, and we can send you a copy. Okay. Before we're joined by our esteemed amyloidologist, I think we're going to start off with Dr. Cara Rosenbaum, who's with us initially. Paula has a few words for us about the passing of a dear friend in the amyloidosis world. Paula?
Yes. On September 11th of this year, the amyloidosis world lost one of its pioneering physicians, Dr. Merrill Benson, to complications from COVID-19. His medical career spanned more than 56 years and included numerous publications and awards. He was a past president of the International Society of Amyloidosis, was certified by the American Board of Allergy and Immunology, American Board of Internal Medicine, and earned a sub-certificate in rheumatology. Dr. Benson saw his first case of transthyretin amyloidosis in July of 1973 at Boston University School of Medicine. In July of 1976, he established the Indiana University Amyloid Center, where they treated patients with AL, AA, ATTR, and other even more rare types of amyloidosis. Between 1979 and 2009, he and his research group at Indiana University described 25 hereditary mutations in transthyretin amyloidosis. Through his continued clinical work and research, Dr. Benson and his contemporary, Dr. Martha Skinner at Boston University, moved ATTR from being almost entirely unrecognized to being a fruitful focus for research, laying the groundwork for today's new life-saving treatments. Dr. Benson was loved and admired by his patients, and his legacy will live on as the University Amyloid Center continues to further the understanding into this disease called amyloidosis. Thank you.
Thank you, Paula. Okay, now we have Dr. Rosenbaum. Dr. Rosenbaum, are you there? You are.
Hello.
Okay, great. We'll be starting with you. You'll be alone for a while. I think our other doctors are at some other meeting. They'll be joining us soon. So Bob, can we have that chart put up so that our patients can know how we're going to be approaching this? And we're going to start off with what is finally considered an official standard of care for AL amyloidosis, CyBorD and Dara. And that chart pretty well explains that we have daratumumab, and then we have CyBorD, cyclophosphamide, bortezomib, and dexamethasone. And now we know that Dara was recently approved. And so let's start off with this. Dr. Rosenbaum, how many of your AL amyloidosis patients that are newly diagnosed get started off with this treatment?
So this came in stages, and we had been using portions of this treatment for years. So all 4 drugs together being daratumumab, and in the trial results, it was the subcutaneous version, so FastPro, Cytoxan, Velcade, and dexamethasone. We call those the 4 drugs. We have been using components of this even with newly diagnosed amyloid for years. Cytoxan, Velcade, with Dex, we've been using since 2012, as everyone knows. So really the addition of the FastPro or IV daratumumab would be similar results if it wasn't in the subcutaneous form. We started using this as soon as it was approved and the data came out. And as a regimen entirely, it's definitely our preferred with all 4 drugs. But sometimes, depending on how someone is doing in terms of if they have heart failure or kidney failure, and you want to give the best drugs up front, but in a slightly gentler way, I have held the Cytoxan, for instance, for the first few weeks or so, and at least so that someone could get the FastPro or Dara and the Velcade and Dex up front. So we call that DVD, but we've given some form of this treatment up front, I'd say, to almost all patients, and give or take some doses of the steroid and introduction of the Cytoxan or doses of the Cytoxan. So yeah, it has been very treatment changing.
Now everyone's concerned, of course, about COVID-19 infections and getting jabbed with the either Pfizer or Moderna or the Johnson & Johnson shot. But we get a lot of questions. Well, if I'm on daratumumab, should I time the shot a week before my daratumumab or a week after? How do you handle that?
Shame on you for asking that, because no one knows. There's no data on this. That we really are using our just anecdotal, and I can say that at the start of COVID last year for the IMWG, a group of clinicians from the IMWG got together, and we have released a consensus report for myeloma of recommendations during COVID. This did include some of these treatments and treatments in general, but we're not only in a whole different place now, but also this did not specifically address amyloid patients. I would, and there are differences between patients with symptomatic myeloma and amyloid, of course. So it really is, there has been no evidence-based data for this. But having said that, and using daratumumab in many patients and in myeloma as well for many years, daratumumab is an antibody against a very early B cell precursor, which is basically turns into the plasma cell of the clone for amyloid. But it really is the reason it works so well in amyloid is it's a very powerful inhibitor and really wipes out your B cells that make any of your antibodies. So, you know, it's really case by case, how much at risk someone would be from COVID, if, you know, of severe COVID, or certainly death if they got COVID, or their, you know, exposure. But, you know, theoretically, if you gave the vaccine and then gave someone their Dara the next day, or, you know, who knows how many antibodies you make, because you've turned off your plasma cells and your antibody making cells for the next few weeks. So, you know, I don't want to give anything that people are going to record. I need to wait 4 weeks, because you know, we just don't have the evidence on that. And we don't even have ways to check titers of you know, for COVID antibodies. We probably will soon. And there's definitely some places that do have titers, and that data will be validated. And certainly a very high titer is promising. But, you know, for now, if the patient is at a lower risk of COVID, severe COVID, or a lower risk, maybe they're getting maintenance Dara, and you can, you know, it's really been case by case. That may not be as true for some of the other drugs like steroids and Velcade. Those are more short acting. They work very powerfully for a few days, and probably, you know, there's effects of it for a few weeks, but the antibody of Dara is in your body for 3 months, and, you know, at least for a month, it's pretty effective. So it's a little longer acting, and you can't really take it out once you give it. So I've also changed sometimes how I've been giving different chemo drugs, knowing that some are have short acting effects. And, you know, you get the vaccine within 2 weeks, you should be theoretically making 80% of your antibodies. So that's really, and that's in patients who aren't immunocompromised and not on chemo. So who knows how the length or amount. So it's just really, you know, we're doing what we think theoretically would make the most sense based on the actions of these drugs. But it's really individual. So I'd say the patient has to check with their oncologist. They should not only check with their other physicians, but also their oncologist, who knows their immune system and the drugs they're getting, you know, the best, and make an educated guess. And as soon as we have titers, then we won't have to be guessing, because we'll know, you know, you really haven't responded to this, you haven't made enough antibodies, and we'll know this. So.
Okay, well, you bring up an important point. If someone is on daratumumab and CyBorD, should they be considered immune compromised?
Well, absolutely. I mean, that's a general term. There's certainly different degrees of immune compromise, anywhere from severely to mildly, you know, and, you know, mild immune compromise, you probably have a very low risk of having a life-threatening or a severe infection. So, you know, you take that into account. But as I mentioned, for the daratumumab, really for a shorter period of time, cutting out your body's ability to make any antibodies, you know, for the most part, that may be enough to fight an infection. I consider that immunocompromised, although it's temporary, because, you know, when the Dara wears off, and, you know, then they're not as immunocompromised. I consider amyloid patients, you know, luckily it's one very good part of amyloid is that their whole bone marrow is not usually taken over by the plasma cells making amyloid. And they usually do have somewhat of an intact immune system compared to some other blood cancers. And we're not just guessing at this. We can measure this based on your lymphocyte levels, your, you know, blood counts, your white count, your antibodies, your T cell subsets. I mean, we can really look at this quantitatively and tell, but any chemotherapy, and depending on what it is, would transiently, I would say, make you immunocompromised from, you know, antibodies affecting, you know, Dara affecting making antibodies. Steroids really affect your T cell function. So any of your cellular immunity, which is half of all of our immunity, including for COVID, everyone's so focused on antibodies. Half of what helps us if we get COVID or any viral infection is our cellular immunity with our lymphocytes. You know, we're not checking that clinically. So the antibodies are only half the story. So something as simple as a steroid at high doses, like we give Dex 40, even Dex 20, you know, these are quite high doses you only get for 1 day, but, you know, and luckily those effects wear off in about 36 hours. So maybe a few days after a Dex, you're not having the immune effects of Dex, but that's not true from, you know, a daratumumab. Velcade, you know, we've given up to twice a week. So that also, you know, the effects within, I'd say, a week are I would say the immune effects are slightly lower. So, you know, it's really different for each drug. Revlimid, you know, we dose every day. So within a few days, you know, stopping Revlimid. Usually patients' symptoms they don't feel like they're on the Revlimid, in terms of fatigue. So, who knows if the immune system bounces back that quickly, but I would think those are more transient effects of immunocompromise. And if someone's in remission, let's say you're a patient with amyloid, and even if you had severe cardiac amyloid or kidney amyloid and you're in remission and you're not getting a maintenance and you're not getting any chemotherapy, I mean, I don't know if it's again case by case. They may have another condition that makes them immunocompromised, or even patients over 65 have a low. We could call that immune compromise because the immune responses aren't as hefty as younger patients. Or so it's multifactorial. It's not just amyloid, but I wouldn't consider an amyloid patient not on chemotherapy being severely immunocompromised from their amyloid. Certainly not. So, so that's a bonus for our population.
Thank you. I would have expected the Q&A to light up, but no one has asked questions. So you must be doing a great job answering.
Everyone must have gotten their booster already. So,
but let me ask you not a non-COVID question, but semi-related. We are also hearing from our patients that those on we heard this when people were on Velcade, they seem to be more susceptible to infection for some reason. And now we're hearing the same thing with daratumumab. They seem to be more susceptible to, colds and flus and even pneumonia. So what is it about Velcade and daratumumab and the combination now that we have Dara-CyBorD that makes people more susceptible to infections, or are they not? Maybe they just think they are.
So for two different things. First of all, individually, not even talking about combining, combining drugs that could affect your immune system, but we're all, and I think we've learned this from COVID, that, even the vaccine, even if you're fully immune, it's not a shield. If you're not wearing a mask and you get COVID from someone who has COVID, you're going to test positive. You're going to get COVID. The vaccines protect against severe illness, hospitalization, and death because you have your immune system and the vaccines, your antibodies to fight the infection. And that's true of any virus. If you're exposed to someone who has a cold, you're going to get a cold. Are you going to get rid of it and have only mild symptoms for 4 days or a week? Or is it going to take you 3 weeks to really clear it because you don't, your immune system is sluggish? You're still going to get the infection. So from COVID, we learned a lot that, it's really about mask wearing to not even have that exposure. And we're not quarantining as much anymore, but really avoiding very, basically common sense situations where you're going to be exposed to a lot of people where you have no idea what their vaccination status is. And that's your best and this would include any infection. So that's your best, if you're really immunocompromised, we've learned that, now it's socially acceptable. We all wear masks. So, and in terms of adding the drugs, so if you are on Velcade and you get a cold, or, Revlimid and you get a cold, you will take a longer time to clear that. Absolutely. You may have worse symptoms. Are you going to go and be in the hospital? Probably not, or a mild pneumonia. So, and then when you add drugs, as I mentioned, the different immune effects of these drugs, when you add them together, so now you're putting a steroid and Velcade and Dara, and you're basically limiting for those periods of time your cellular immunity, your antibody production, especially if you're trying to give someone a vaccine and actually force your body to make antibodies, it's probably not going to happen. But even suppressing your memory B cells, which are our memory cells that have all of our antibodies from other vaccines in the past that we're already immune to, even that's suppressed for a period of time. So all of your immune system is going to be lower. Now, having said that, we have data from Dara-CyBorD from the trial, the Andromeda trial, and the very first data that came out last year and in the Blood publication last year in July was the safety data and the amount of infections that we actually saw for patients on this. And this was obviously pre-COVID. The cutoff of analyzing that data was before COVID, so it did not include even the articles last year did not include patients with COVID or risk to COVID. That's completely, we don't know that, as I mentioned, in this population. We all have anecdotal reports of our patients amyloid patients who've had COVID and how they've done, but this data from Dara-CyBorD would be for any other infections, whether it's a common pneumonia, cold, any viral. And the rates of serious infections were very, they weren't zero, but they were acceptable. They were at a low enough level where the majority of patients were not getting severe infections. And also with very close monitoring by their doctor, notifying their doctor for the first day someone has symptoms. I scold my patients if they have not called us, because we don't know if it's just a cold. We may want to hold your therapy. So very close monitoring. I think you can still get mild infections, colds, and those are more common. But we think that it's worth, obviously, the benefit of saving your heart, saving your kidney. I mean, these are, that's certainly a benefit, more of a trumps that. So
thank you. Okay, we have one question before we move on to a new subject. We do have a question from Mike, who says, "Hi, Dr. R." That's got to be you. "I tested COVID positive, yet only had minor illness despite my other conditions. Has the cancer chemo community found this to be common?" So have you found people having minor illness that test positive? He doesn't say whether he was jabbed or not. So
I think I know it is one of my patients. And if I'm recalling correctly, that was during the main COVID last year. And the Delta virus and these variants that are going to come up are very different than the main. So all of our data and our vaccines are all to the initial variant. So having said that, and so I won't talk about Delta yet, but talking about the first variant, it was really very dependent on so many variables. The amount of disease infection you got, you may have only had been exposed to a very small amount, and it, in your nose and your mouth, and maybe didn't even get into your lungs because it was such a small amount. That person may only have mild infection and mild symptoms, and it may be easier for them to clear it. Although our patients on chemotherapy did take a lot longer to physically show that they were clear than a general population. And these are with the PCR tests that are so sensitive. I mean, it's picking up any little amount of virus left, but even that, it does take longer for patients to clear it, which would be that that patient's still contagious for a little longer. But they may only have mild symptoms if they have a lower amount of viral load that they got. And then your immune system comes into play. I mean, we held, last year we didn't know what was going to happen. So most patients who could, we held their chemotherapy for a period of time, some people even a month or two, and if they were in maintenance and they were in remission. And so they did hopefully capture back their immune systems to be able to fight, that may have played a role. With Delta though, Delta's doesn't, from the lay literature, it hasn't caused a more severe infection, but it is a lot more contagious. And initially about a third of patients were not even symptomatic with Delta. And it may again be because they have a low amount of viral load that they got. So they're partially vaccinated or vaccinated. So they really didn't get a chance to get a more deep-seated infection. But there's people walking around who have Delta, and again, maybe at lower levels, that you don't even know, and that they don't even know. So that goes back to wearing the mask, avoiding social, until we know more. I mean, every few weeks we learn more and more. Probably the winter is going to be more risk again, like it was last year, more indoors. So I think heading into the fall, winter, like we used to say for flu, this is no different. The flu season in the winter, that was the at-risk season. It's the same thing. So
thank you. Okay, we'll move on now. Now, when we were discussing Dara-CyBorD, of course, we talked about Cytoxan being one of the ingredients. Okay, and Cytoxan we know is an alkylating agent. So we'll go to the purple column here, alkylating agents, and discuss them and how they fit into the treatment plan for amyloidosis. So the first one that's listed is oral melphalan, also known as Alkyran. So we know that some of our older patients or treated earlier on might have been treated with oral melphalan called Alkyran at the time. And of course, melphalan is the drug they use high dose for stem cell transplants. So if you could run through the alkylating agents and tell us how through the alkylating agents and tell us how they work and do you use them still? That I think everyone will want to hear that.
Sure. Alkylating, I didn't mean to, when I was talking about, Dara-CyBorD to minimize Cytoxan, it is a very good drug, and alkylating agents are very good drugs. I was discussing more timing of sequencing of getting in, when someone's first diagnosed and has a lot of symptoms, because you do want someone to get drugs. The last thing you want to do is give someone a dose a month, 1 week, and then they get sick and you can't even give them any more treatment. So you have to, think about like that. But outside of that setting, alkylating agents, the first three we have here, both the oral and IV melphalan, and everyone, as you mentioned, knows with IV, this is what our transplant is. We come in for our auto transplants. You get the typical is 200 million, the standard dose is 200 milligrams per meter squared. Sometimes there's a dose reduced amount that we can give, and it's given in 1 or 2 infusions. And anyone who's had a transplant knows the effects, and these are very powerful side effects because this is such a high and potent dose of melphalan. If you go to oral melphalan, the reason that patients did better with a transplant up front, and why we've been doing transplants for decades in amyloid and switched from oral melphalan, is you are able to essentially to get all of that melphalan 9 months in one shot, whereas it would take 9 months, giving with the oral, some newer patients may not know this, but with the oral melphalan, and that's all we had for some periods of time, even pre-Velcade, was 4 days out of every 28 days, so every month at 4 days a cycle. And patients had infections. I mean, it really lowered your immune system for that month, and it wasn't necessarily easy, especially with high doses of steroids we were doing at that time. But the problem there was that very few patients went into a very good complete response or any organ response because it just took too long. It would take months and months to get in the amount of melphalan that you could give in one shot with the transplant. And that's where we saw improvements in survival and organ responses, heart failure. So now Cytoxan is also an alkylating agent. It's in the exact same class. Alkylating agents, we use these terms kind of like, everyone uses them every day. But what that is it's I think of it more as like a bomb of chemo, like your standard classic cytotoxic chemotherapy that we've had that, many patients with other, maybe breast cancer, the purpose, it is not specific for the plasma cell at all. But it is powerful, and this includes Cytoxan, and it basically, any cell that is multiplying, so usually cancer cells are multiplying quickly, at the point that the cell is actually dividing and turning into another cell, it literally, it exposes the DNA at that moment, and the alkylating agent is able to stop that process. The cell is sensitive to this drug. It's a DNA killing agent when the cell is dividing. And, the rest of our cells in our body aren't dividing every few minutes or every, our blood cells in our bone marrow, our hair follicles, and our GI tract lining are the cells that divide most quickly. And that's why during a transplant, the days, you get the IV melphalan, you have those side effects because that days you got the melphalan, it killed some of those cells and they of course regenerate and come back. But the benefit is any cancer, or specifically we know, myeloma and plasma cells and amyloid are very sensitive to this too. I mean, they're killing dividing active cells. This is very different than any of our other drugs in amyloid because they work and target the plasma cell differently than affecting ones that are dividing actively. So Cytoxan, we have a lot of flexibility with it because we can make it more potent or less potent based on the dose. So we can give many patients who may have not, during their transplant tried to get mobilization with the Neupogen and the G-CSF, the Mozobil, and sometimes that they aren't able, they don't respond to it. We would give high dose Cytoxan, like a standard chemotherapy. And you'd have similar side effects for a few weeks as if you got a mini transplant, and then you can get a lot of your stem cells that way. We don't do that in an outpatient setting. We give a small weekly dose of it So it would take months to get that same amount of dose we could give, and theoretically in one setting with a large dose of IV Cytoxan. So, we have a lot of flexibility with these drugs. There's oral Cytoxan, just like there's oral melphalan. And, with dosing, and by dosing the different levels, we can, we can control the side effects that we think we'll see with it. So these are great add-on drugs. I consider Cytoxan where you wouldn't, most people would not get Cytoxan only for treatment of their amyloid, because it's alone, it will not have the same, at lower doses, it will not have the same responses as a Velcade, as a Dara. At high doses, yes, but that gets, toxicities. So those are the story of the melphalan and Cytoxan. Bendamustine is a more unique alkylating agent because it has a portion of how it works as an alkylating agent, and another portion is something that we use in other cancers like leukemia. It's called nucleoside analog. But we use bendamustine in amyloid and myeloma based on the alkylating nature of it. And it's one of these, they pulled this drug from the grave. It was an old drug, and most people probably know the story of this. And, probably like 15 years ago now, 20 years ago, researchers rediscovered it and kind of picked it out and said, what's this? And it had great results in myeloma. It's used in, obviously in CLL, a lot of other lymphoid cancers is one of the main ones. In amyloid, there's actually Dr. Lentzsch joining us soon, can comment, because this was her study, she reported it and published it in relapsed amyloid. So we wouldn't give bendamustine in newly diagnosed. We have drugs that have very few side effects that may work better than it in that setting. But in a patient who may not respond to Dara or Velcade, or maybe couldn't get a transplant, or is just not responding to other drugs, her data was very good. It showed very surprisingly good results for patients who weren't responding to other drugs. So
with the bendamustine, that would be used perhaps in a refractory setting where other treatments aren't working, or if someone has maybe Waldenstrom's or an IgM type of situation, right? Correct.
It would not be in newly diagnosed. These were patients who had a lot of other prior treatments before they got it, but it worked pretty well. So, could it be used earlier? That's a question that hasn't been looked at yet. So in amyloid. Melflufen, the reason people probably haven't heard of it is because it's certainly not given in amyloid yet. There are trials underway. It was recently approved in March for myeloma. And as we all know, in amyloid, when things are approved for myeloma, then we start being able to use them in amyloid, So now it's a very nice period where, and we're working closely with the companies, and they're designing trials possibly for amyloid patients. So more to come on that, and maybe another year or so until we have data. But we certainly have a lot of these other alkylating drugs in this class to work with in the meantime.
Is melflufen, I kept calling it marshmallow fluff or something. So is that like a new, more powerful version of melphalan, or a kinder, gentler melphalan, or exactly what is that?
So that's a good way to think of it. It is a more powerful way. It's actually, it's kind of similar to the bendamustine story, where it's two kind of mechanisms of a drug tied into one. So one is the standard alkylating, which I explained with the hitting the DNA, cells dividing. And then the other, and it's a brand new treatment, it's called an aminopeptidase. And the purpose is that it's similar to melphalan, but it is more targeted into the cell specifically. So instead of affecting globally any cell that's dividing, like I mentioned, very sporadically, it is really focused to plasma cells, is taken up, and it's the benefit of that is that it could be more potent to the plasma cell with less side effects. So of course, that's what we always want. We want to kill the cells more and have less side effects while we do that, because then you can give more higher dose, you can really kill a cell a lot more. So it is a brand new treatment like that, and it's very focused to plasma cells. In myeloma, it does have side effect. It's given on a cycle every month, and you can get it as an outpatient. It's an IV infusion. it is powerful, and we do see higher rates of infection with it, and so it has to be in the right patient who can tolerate that. But again, we have not studied this in amyloid, totally different
Is there a clinical trial going on with it in amyloid?
There's one that's being discussed. There's one that's not active right now, but I don't know for sure, but I know there's been a lot of discussions. I can't say when or if one would open, but there's been a lot of discussions about if we could study this in amyloid patients safely.
Okay, well, Carol asked a question. I was told by my local oncologist that melflufen was put on hold about a month ago. Would that refer to that trial that you were talking about that is not active yet?
Melflufen so that's not a trial, that's actually the drug that is approved in myeloma. So the hold was meaning that they were analyzing some data, and that they'll release the hold when, sometimes the FDA will make changes in the who should get it or the label, but that does not apply to anything with amyloid, and it does not apply to any potential. I mean, we'll learn more, but that was specific for myeloma. So.
Okay, so is melflufen something they might consider for stem cell transplants in the future in place of the regular melflufen?
That is one of the settings it's being studied in, and in myeloma again initially. When we design trials for amyloid patients, we really need, we want to know, and have for safety first, and make sure that it's designed in the right way with the right doses, the right population to study. So, that's why we always see our drugs in amyloid being approved, either never on a label, but approved years later, where we can get it for. That's unfortunately what the situation is, and it's from a safety standpoint that, the drug makers, they don't want, they have, it's a safety issue because it hasn't been studied in amyloid patients yet. But sometimes there can be helpful data where someone may say, for instance, there was a report by Dr. Sanchawala who this was last year, who released, she had treated a patient with selinexor from amyloid. And so even though that's not approved for amyloid, they reported anecdotally a patient and how that patient did. And that kind of information helps us. It's not that now everyone's going to do that because of one patient, of course not, but it helps get the excitement there so that we can then propose to the company, we want to study this. And actually that's exactly what I'm doing. We have a trial opening very shortly. It's a joint trial with Cornell, and Dr. Lentzsch is also going to open it at Columbia. We're working on it together. And it's studying selinexor in amyloid patients with relapse disease. But I'm just using that as an example that there can be reports that come out, or small series. That's how CyBorD was approved. It wasn't a trial for amyloid. Multiple different centers, Mayo and in Canada, reported on a small 18 patients, 20 patients, 40 patients, how they did, with these drugs. And it looked phenomenal. And that's how we started using it. So
what is selinexor?
So selinexor, so it's a drug we use in myeloma, and
We don't have that on our chart. Should I add that to our chart?
It may be a little early to put it on the chart because it is, it's not even on our study's not even open. So we may hold that. I don't want people to start.
Which column would it go in? Which column?
So it would likely go in, it's a novel agent for it would go under, I wouldn't, the Venetoclax being a BCL2 inhibitor, I would put it in a novel agent category for now. But we will know. We may have data in a year after our trial opens, and we'll report it as soon as we can. And, and then that will show the safety and how well it works. Because you cannot, this is 101 of amyloid. You cannot take something in myeloma and say, look how it worked. Okay, now no, absolutely not. No. And it's for the benefit, it may be that amyloid patients can tolerate a higher dose or a lower dose or a different schedule.
We do see that daratumumab and Velcade seem to be more effective in amyloid than they are in myeloma.
That is a very insightful point. And we understood that after the fact. No one predicted that. We're like, well, why is it better? And because amyloid is more focused on the plasma cell makes more light chains. It's a more light chain making machine than patients with myeloma may not make as many light chains. And so And even tests like the Mayo's doing, the MALDI-TOF test, those are very sensitive for light chains. So these kind of things are beneficial for amyloid because they work better. But we wouldn't know that if we took the same data and did the same schedule and results always from the myeloma people. You may be under treating someone. So yeah, we need our own trials, or we need reports of how people with amyloid do from these drugs.
Okay, before we leave the alkylating agents, okay, what I'd like to, okay, let's talk about adverse events with the alkylating agents, okay? Because what can people either not look forward to, but what can people expect if, let's say, they're on oral melphalan, or they're on a cyclophosphamide, or Cytoxan, or bendamustine, or melflufen? What kind of events have been reported that they should be concerned about or not concerned about?
So I don't like any patient thinking it's all one box, because honestly, it's so related to the dose and schedule you get that your doctor could give you it in a way where you may have no side effects. Now that may be a lower dose, could still maybe do help, but I think you would really have to ask your doctor, what is my risk of these side effects with the dose I'm getting and the amount I'm getting, the schedule. Having said that, they're all similar to our IV melphalan transplant. As I mentioned, the cells that are at risk are our GI lining tract cells. That's why when people have a transplant, they don't want to eat for a few days. They feel nauseous. It takes them a few days to get their appetite back. It comes back, 100% comes back. The cells regrow. They just take a week or two. And then the bone marrow cells, our bone marrow cells, all of them are actively dividing every day. They're fastest cells in our body, dividing and multiplying. So those are affected by melphalan, and with high doses, it wipes out your bone marrow. Then you get your stem cells back, which is why we have to collect stem cells. But then when you take these other alkylating agents that aren't given at high doses that we can give out, like oral melphalan, oral Cytoxan, IV Cytoxan weekly, these are much lower doses. They may have minimal amounts of those same side effects. You will, at lower doses, most patients will not lose their hair. Now, if you give a higher dose, you could, and of course it grows back, but it can suppress that. But at lower doses, it likely won't. Maybe my patients on weekly Cytoxan may say, oh, your hair may thin a little. It's completely reversible. As soon as you're off of it, it comes back. But you're not going to lose it all like you were getting a transplant. And you may have, if you're getting Cytoxan, once a week, you may not really have any side effects. You may not have any nausea. And we can also prevent that. We can, if someone's going to have diarrhea from Cytoxan a day after they get the dose, well, take some Imodium that day. You won't even have it, and again, these are mild levels of these side effects. But
what about the cardiac and kidney issues? Should people who have cardiac AL be more concerned about any one of these alkylating agents than any others?
So the good news is that these drugs are not specifically toxic to the heart. So there's no direct toxicity to heart muscle. Now, patients who have very symptomatic, who are still having symptoms from heart failure on, their diuretics, on their heart medicines, the patients that who have that, or patients who have kidney failure, and both of those similarities there are you're very sensitive to fluid shifts in your body. So if someone in those scenarios, they're very dependent on having the exact same level of amount of fluid in, fluid out, and when any of that rocks the boat, they can have issues, and they may need help with extra doses of Lasix or diuretics. So that applies to infections. Let's say you have an infection and you're not eating for a few days from a cold, that can have an effect, mild. Or, if you had, something like that. So, if you're affected by, let's say, during your transplant and you're not eating for a week, well, you need to be under observation and probably get some IV fluids to counteract that. So, as long as your doctor should be aware of this and helping you and saying, drink more, drink less, but a lot of it has to do with volume, fluid in your body, and not direct effects against those organs.
Okay, great. I think we've handled the alkylating agents. You did a great job. I think, if anybody has any questions, the questions that have come up relate to things that we're going to be discussing, soon. But someone did, okay, Doug asked the question, does melflufen cause hair loss like IV melphalan?
So IV melphalan, there's a caveat. You could theoretically get low doses of IV melphalan in your doctor's office outpatient, not as a transplant setting, not as much, not really depending on the dose. But what we're talking about is the high dose given for transplant. At that high dose, yes, that day you get it, that episode of you will lose your hair and it will all grow back. But these other doses these other ones we're talking about as giving outpatient, IV or oral. Really, you won't have total hair loss stuff. No, not at those levels.
Great. Okay. And some of the other questions you've been sending in, as we discuss the drugs that you're referring to, we'll answer those questions. All right. Now we're going to move over one column to our proteasome inhibitors. Okay. And bortezomib, also known as Velcade, carfilzomib, also known as Kyprolis, ixazomib, also known as Ninlaro. And then we have marizumab and oprozumib. So they all end in MIB. What would that stand for?
That's good. I mean, if you notice on the antibody column, they all end on MAB. So
Right.
That's monoclonal antibody. To be honest, I don't know what the MIB stands for. It's not an antibody. These are not antibodies.
Well, we know that the I probably is inhibit.
Maybe, I don't know. That's actually not. I mean, these are the trade names, Velcade, Icros, and then these are the generic names. I do not know the history of the naming of bortezomib.
Well, when the other doctors join us, we'll have
Maybe
to
they
ask,
will know.
We'll test them.
That's very interesting.
They know. Okay.
I bet someone who was, active in picking the name of bortezomib may know. But I'm sure there's an answer to that. But the MAB in amyloid and myeloma and any disease is a monoclonal antibody. It means that it was made either in a mouse. It's an antibody that was made, for that specific target, like daratumumab against, CD38. So sorry, do you want other questions on the proteasome inhibitor?
Well, let's start with the first and most famous and the one that was a game changer for amyloidosis, which is Velcade. I mean, because those of us that were here before Velcade saw the difference that Velcade made. I mean, we saw that treatments were taking a year to have an effect, or 9 months, whereas with Velcade we saw treatments taking effect after 2 or 3. After 2 or 3 treatments, we saw light chains going down, down, down. So that was pretty darn exciting. So with Velcade, though, what would be we know that Velcade can cause neuropathy, and it can be very difficult on a patient. So are you seeing a lot of neuropathy with people on CyBorD, or do you look at someone who has neuropathy and say, hey, we're not going to give you bortezomib, or we're going to lower your dose, or we're going to do an alternate? What do you do in cases like that?
So that goes back to dosing. It goes to a couple of variables. And let's say first you have to look at it in the regimen you're giving it, like you mentioned, CyBorD or Dara-CyBorD, and now we're doing that newly diagnosed. But there's patients who will certainly get Velcade, if they had a treatment up front, then went to transplant, and now they're getting Velcade. That certainly, it doesn't always have to be newly diagnosed. But in the schedule of the CyBorD, it's given once a week. I mean, I've given myeloma, we've given patients twice a week Velcade. I mean, I've done that occasionally in scenarios, but it's generally once a week. And the reason it is generally once a week is because it's a much lower rate of development of neuropathy, much lower than more than twice a week. So with once a week, you also have to look at, does a patient have an underlying history of neuropathy? If they have diabetes, they could have amyloid neuropathy, where their amyloid is affecting in their soft tissues, like their skin, their tongue, their nerves, their muscle, from when they were diagnosed. Those patients, they may even have overt neuropathy already, where they have symptoms, or subclinical, where they don't know they have neuropathy, but there's already some, decrease in or some damage, micro damage to the nerve. And you could piece that out with, certain tests, but they may not know. Those are likely the patients who, when were more sensitive to Velcade, if the patient got a lot of Velcade, or had higher doses, or twice a week, that, they may have been the patients who may have some symptoms of neuropathy. In general, the having neuropathy from Velcade is majority are reversible. By reversible meaning when you stop the Velcade, your neuropathy will either go away completely or get much better. And that's always what we see. I can't remember any patient where I've stopped the Velcade if they were having that and it stayed exactly the same. I mean, unless their neuropathy was from something else, like their amyloid disease themselves.
What about those that got IV Velcade before Velcade was a sub-Q shot? I've heard about some of those people having severe neuropathy.
Absolutely, that's a great point. And that, you know, of course, we saw all this initially in myeloma patients, and then trials were done between IV and sub-Q, and all of a sudden the patients with myeloma with sub-Q had 1/6 the rate of neuropathies. So, and it has to do with how Velcade causes neuropathy. And it's actually, and the reason that, you know, carfilzomib is a cousin and Inlara are cousins of bortezomib, we're not seeing neuropathy with those. Why? It's because of a toxic metabolite from the Velcade. And then it has to do with someone could get the highest doses of Velcade and never get neuropathy, but then someone else could get low doses. Why? It's because everyone's sensitive in different ways through metabolism. So you also don't know until you start getting it. You may never get neuropathy. You know, the majority of patients with amyloid never get it. Now, luckily, if you get it, it's not something that typically happens overnight. It's not like that. It's very gradual with someone asking you, do you ever feel, you know, once in a while, like you will see these signs coming on. And if you have the signs coming on and it's either the dose is lowered or it's changed or stopped, it will get better. And so, you know, I usually, of my patients who are, you know, worried about that, or patients who may have other underlying neuropathy, we have to be extremely careful. You know, we can usually reassure that if we're watching it closely and we stop it, if you have only early or mild symptoms, it will get better. So, so that, you know, that's pretty reassuring. But we don't give IV Velcade too often because we don't need to. You know, we have oral, we have subcutaneous, just like Faspro. I mean, there's data that the Faspro, the sub-Q Dara and the IV Dara were the same efficacy, but much lower side effects in terms of the Faspro being the injection site reaction was much lower than the initial infusion reaction for Dara. And same here, the side effects are better with subcutaneous versus IV. Now, there's no danger if you're in the hospital and you had to get a dose of IV Velcade. Nothing's gonna happen if you get one dose of IV Velcade. Nothing in terms of neuropathy. I mean, you know, you can get a dose here and there, but this is as a schedule, you know, where you're getting it routinely.
Okay, now we know that people who are taking Velcade are automatically put on an antiviral. Why is that? Why is there concern about shingles with Velcade? What does Velcade have that causes that?
Great question. And that we see in our myeloma patients as well. And it's still, you know, that gets back to what if people were on initially when we were talking about how Velcade and proteasome inhibitors influence the immune system, you know, versus other drugs we have. So Velcade, it does influence the immune system, and usually shingles, which is, you know, some patients may have had it. It can be, again, mild flare. It can be a severe flare. It can be horrible. It can be mild. You know, it has a lot to do with what's your immune system already. Because a lot of us, we've been exposed. We've had chickenpox. We all have the herpes zoster virus. A lot of us have it. But if your immune system is active, it's suppressing it, so it doesn't become flared into the nerve, and you see the blisters on the skin. But if your immune system goes down, then you're susceptible to it flaring. And any chemo in general, anything we give could theoretically make you susceptible, whether it's Dara, you know, we're lowering the immune system, but it's the way that how Velcade lowers the immune system where we seem to see that more with Velcade. And Velcade affects our, you know, we don't have a lot, you know, the infection risk on Velcade is not very high. I mean, it's related to the dose we're giving, but it does have effects on your cellular immunity. It doesn't, you know, it's not the same as a daratumumab, decreasing your antibody production as much. I mean, we can measure that, but what happens is it suppresses your immune system while you're getting it. You can get shingles. I've seen that. Usually it's not after a dose or two. I see that, I'd say, in maybe 1/6 of my patients with not just amyloid with myeloma. Maybe after the first 6 months of their treatment, they can get it. But this is what is very important And actually, the data, at least in myeloma, can show that we can prevent shingles 100%. There's not a lot of things we can say we can prevent 100%. If you are taking the right dose of an antiviral medicine, being acyclovir or valacyclovir Valtrex, or on the right schedule. So I guarantee, time and time again, when a patient gets shingles, they have ran out of their acyclovir or Valtrex for 2 weeks, didn't think it was important, did stop taking it. I've had a patient that stopped taking it for 2 days and they got shingles. But I can't remember the last time, or if a patient's taking a too low of a dose for them, I cannot remember the last time I had a patient taking the appropriate dose who got shingles. It's really, we can really prevent it. So prevention is the key there, and it shouldn't limit us from being able to use it as long as you're having very close watch from your doctor. If you run out of meds, you're calling the clinic. You're not waiting. You know, you ran out of a med Friday night. You're not waiting till Monday morning to call the clinic. You're calling and you're talking to the after hours. I ran out, please. You know, that's really important, and people don't realize that sometimes, that it can be that sensitive to it.
Yeah, I do want to stop for a second and welcome Dr. Laura Dember to our panel. Dr. Dember is the nephrologist at the University of Pennsylvania. And when I first met Dr. Dember, she was the nephrologist at Boston University Medical Center. So, and Dr. Rosenbaum, we had Dr. Dember as a guest of a meeting in New York at Weill Cornell.
Hi, hi, how are you?
Good, hello.
That seems like so long ago.
I know, it was in person, wasn't it?
Yes, it was in person in 2018, maybe, whatever. I'm not sure what the year was. But yeah, it was a while ago. Thank you for joining us, Dr. Dember. You can see the therapy chart that we've been discussing. And we discussed CyBorD, and then now we're kind of breaking it down. We just did the alkylating agents and discussing those, and Dr. Rosenbaum has been, answering all my questions so patiently, and also we've been discussing the proteasome inhibitors and the adverse events. And since you're the premier nephrologist in the entire world, with amyloidosis, do you ever see any adverse events that relate to the kidney in any of the alkylating agents or any of the proteasome inhibitors?
Yeah, with the alkylating agents, we don't often see kidney effects, except that we know are directly from the drug. With high dose melphalan, that's used for stem cell transplant, it is not uncommon for people to get acute kidney injury. Often it's mild, it's not always mild, it's usually reversible. And whether that's specifically from the drug or related to kind of everything else that goes along with stem cell transplant is not totally clear to me. I don't Cara may have another view about that from an oncology perspective, but melphalan in general, I would say, is not nephrotoxic or kidney toxic. With some of the proteasome inhibitors, it's rare, but there are some kidney effects. There's something called thrombotic microangiopathy that is an unusual complication of that we've seen with proteasome inhibitors. It occurs with other drugs as well. It's not at all unique to proteasome inhibitors, and it can occur for other reasons other than a drug effect. That's rare, and I would say it's particularly rare with bortezomib. We don't see it often with bortezomib. I think we've seen it more with carfilzomib, which I don't think that is on your list. Carfilzomib, we've seen it maybe a little bit more with ixazomib.
That's interesting. Okay, so now we don't have a cardiologist joining us today, unfortunately. But I think I saw something recently that Dr. Lentzsch did a presentation and mentioned that she was not a fan. I think it was carfilzomib, Kyprolis, and it had some cardiac toxicity related to it. Does that also have kidney toxicity as well?
Yeah, I mean, I think the kidney toxicity with carfilzomib is probably most of the time. I mean, these are kind of rare events, and unfortunately, most of these patients don't get kidney biopsies, so it's really a little bit hard to tell exactly what's going on in the kidney. But there can be worsening of kidney function. I think the best described kidney lesion is this, what we call thrombotic microangiopathy, where there's sort of tiny little blood clotting and sort of the endothelial cells, which are the cells lining the blood vessels in the kidneys, get kind of injured and activated. There also are case reports of what we refer to as interstitial nephritis, which people have seen with carfilzomib. It's also actually been seen with Velcade, with bortezomib, although I think, less commonly. So yeah, I think if I had a patient with significant underlying kidney impairment, I would be a little bit nervous about carfilzomib. Sometimes we have no choice. That's, particularly before there were all these other options. Now there are other options. So yeah, I think I would agree with what you, what Dr. Lentzsch, it sounds
Laura,
like said.
I have a question. Would you include, I agree, we've had case reports of carfilzomib and myeloma and plasma cell. Would you include any glomerulopathy with prior glomerulopathy, or mostly patients who have more like renal failure for the carfilzomib? Have you seen any cases of patients who have prior glomerulopathy issues?
Well, I don't know that I can sort of separate out, I think the people that I'm more concerned about are people who have reduced GFR, which might be because of tubular disease. It might be because of glomerular disease. I don't know that we have enough. I don't feel comfortable saying that one group is more at risk than the other.
I was just curious.
Yeah.
We have had, and Dr. Lentzsch, I reported it as a report.
Right, we've got Dr. Lentzsch joining us now. So school must have let out, guys. So we have Dr. Lentzsch joining us. Let me fill you in, Dr. Lentzsch. Dr. Rosenbaum beautifully broke out, CyBorD for us, and we went through the alkylating agents. You can see on the chart, and we're going through the proteasome inhibitors now. As a matter of fact, I mentioned your name. I mentioned that I recently read something that you weren't a big fan of carfilzomib. Would I be correct in saying that?
You mean carfilzomib and amyloidosis?
Yes.
I don't know how you kind of mean this, but I would not use carfilzomib and amyloidosis.
Right. Well, that says it all, doesn't it?
Yeah. No, I don't know whether you discussed it, but we had a couple years ago a clinical trial, and Dr. Adam Cohn from UPenn was leading that trial. Unfortunately, I don't think that he has published the data, but we completed the trial. I think it was a phase 2 trial, carfilzomib dexamethasone, and the data were not good. And the conclusion was that we should not use carfilzomib in AL amyloidosis. Always you have selected cases, and you might have a good response, but in general, I would discourage use of carfilzomib in amyloidosis.
Well, there's no doubt about that statement. We appreciate that a great deal. Let's go down to ixazomib, Ninlaro. That's sort of like the poor man's Velcade, I guess, only it's oral. So, and that trial did not prove, everything that people wanted it to prove, I think. So, let's start with Dr. Rosenbaum. Dr. Rosenbaum, what are your feelings on Ninlaro, ixazomib?
So yeah, I think those are accurate statements. Everything you just said is accurate. There's definitely, it's on the list because it works, it's there, and it does what it claims to do. I think similar to myeloma, we've used it less as a primary drug for the first time someone's gotten a proteasome inhibitor. And, we really, in amyloid, still prefer Velcade for that. There's just so much more data, and we know Velcade works, and we understand the side effects and what to watch for. But there are cases where it's been nice, even especially during the pandemic, where if someone couldn't come in and you couldn't monitor them, they couldn't come in for their chemo, you could. And I have some patients. I have a patient who's homebound who, they're on Ninlaro. So, there are cases where it's been extremely useful because it's safe, it's really easy to monitor side effects. And so, and it's tolerable. So I don't know what other people's thoughts are, but I would, for myself, prefer Velcade if I'm giving it alone or with in combination. I mean, Ninlaro is not approved with CyBorD or, with Dara-CyBorD, so you wouldn't do that anyway. But, but these are outlier cases, I would say.
Thank you. Dr. Lentzsch, where do you stand on Exazimib and Ninlaro?
Yeah, so I mean, there's no question for newly diagnosed amyloid patients, we would use Velcade within Dara-CyBorD. In the relapse setting, I think it looks a little different. The clinical trial was negative in terms of primary endpoint. So primary endpoint means, what was the primary goal of the treatment? And the treatment did not show that the response rate was really superior with Exazimib dexamethasone compares to physician choice. So whatever treatment the physician wanted to use and choose among three, I think, different treatments. Nevertheless, there was a significant increase in the duration of response. So patients who received Exazimib dexamethasone were longer without a progression of the hematological response. So that is, I would say, somehow encouraging. I use it, for instance, in patients who do not tolerate Velcade. So we see a lot of GI toxicity, cramping, diarrhea with the Velcade, much more than we see in multiple myeloma or neuropathy. I think here we have Exazimib as an option. Not my first choice, but my second choice, or for instance, in combination with Venetoclax, when patients do not want to come in and they stay on their oral Venetoclax in combination with a proteasome inhibitor and here Exazimib. So I have quite good results with Venetoclax Exazimib.
Thank you. Let me ask you, we won't ask about carfilzomib because nobody likes it, but let's go to Exazimib and Ninlaro. Would one want to take an antiviral to prevent shingles with that as well, Dr. Rosenbaum?
That's a good question. In the trial, I don't recall, I actually don't recall if patients were on prophylactic. I believe they were, or it may have been physician choice. But I would, but also that has to do with the time from their transplant. I mean, there's other things, there are other immune status that I would influence whether I may have someone on an antiviral or not. With Velcade, we always use an antiviral, regardless of anything else. So I'd prefer, but it hasn't been as mandatory as Velcade.
Dr. Lentzsch?
Yeah.
What about you, acyclovir?
We as our institutional policy and we as a group, we decided to give antivirals for all proteasome inhibitors, regardless whether it's Exazimib, Velcade, or carfilzomib, and also to all CD38 antibodies.
Okay,
So
yes. There was a question that someone asked. Can one be on acyclovir indefinitely? Is there an adverse event to that we know of? Dr. Rosenbaum?
No, I mean, you're monitoring it. If someone's kidney function changed in terms of their, not their proteinuria necessarily, but their GFR, then you would need to very closely monitor that and very likely adjust doses. But short of that, and then sometimes we see people have sensitivities to it when they first start it, a rash, especially we've seen that more commonly in patients who are also getting IMIDs at the time, more myeloma. So there are patients who are sensitive to it, but if someone's tolerating it and their kidney function's fine, there's really no long-term side effects. It's a very safe drug.
Okay, Dr. Dember, Dr. Rosenbaum brought up it could be some kidney side effects. What might someone see if one is on acyclovir?
Well, with the oral preparations, the kidney toxicity, the damage to the kidneys is much less common than when people get kind of high doses of these drugs intravenously. And that's because when you give it intravenously, the concentration of the drug that reaches the kidney tubules is very high. It kind of all of it gets there at once. Whereas when you're taking it orally, it's absorbed gradually. And so one of the things that can happen with these drugs, but again, this is really unique to the intravenous administration, is they can precipitate within the little microscopic tubules in the kidney and cause what we call intratubular obstruction. But we really don't see that with the orally administered acyclovir or valacyclovir preparations. What can happen is the clearance can be reduced, clearance of the drug, if there's significant kidney impairment. So there can be non-kidney toxicities related to having higher concentrations of the drug. And that can be addressed by reducing the dose of the drug, as Cara said.
Okay.
one thing that we see sometimes if the dose is really excessive, which it might not have been excessive if they have normal kidney function. If kidney function is reduced, it might end up with, there may be too high a concentration of the drug. There can be a CNS, a central nervous system toxicity with kind of an encephalopathy. It's very rare to see that, again, with the orally administered drugs because the dosing is lower. But in hospitalized patients, we sometimes see that from just really from the dose being too high.
Super, great. And Dr. Lentzsch, so you don't see any problem with people being on acyclovir for a long time?
No problem. But keep in mind then for amyloidosis, we usually do not give maintenance, So I give the antivirals as long patients get treatment, but then usually I also stop them and have them only on observation if patients are in complete remission and do not need any treatment. But in principle, the answer is yes. In multiple myeloma, we continue indefinitely as long as patients are on maintenance with a PI or with daratumumab and need the antivirals.
Well, and this brings up something that's discussed all the time, what used to be discussed all the time when we had live meetings, and that would be the drug Shingrix, and which is, not a live, vaccine. And I remember the first time Maury Gertz talked about it at a meeting. He said everyone should get the Shingrix shot, everyone. And my husband and I went out and got it. It cost $200 because our insurance didn't cover it, and it was 2 shots, I think. So, where do you stand with the Shingrix shot, Dr. Rosenbaum?
In our whole discussion about vaccines and responding, I mean, I would time it based on what we talked about to maybe you're not going to get it right after you gave you got daratumumab, so you can respond. But short of that, I think it's not going to hurt. If I had to choose one or the other, I would trust being on an antiviral more than just having the Shingrix. Going back to, we don't know how your immune system responds to it. I know if we're giving you a pill and you're taking it, it will work while you're taking it. So a lot of patients do both. They'll get their double Shingrix and then but then they'll say, can we come off? Can we come off? And it's a case by case. If someone's at a very high risk for shingles, I will probably not, even with the Shingrix. If someone has very low risk, or as Dr. Lentzsch mentioned, they're not even on treatment, yes, they can likely come off.
And Dr. Dember, what are your thoughts on Shingrix?
Yeah, I'm all for it. I got my Shingrix vaccine too. So I think just as Cara said, that the question of whether whether someone will respond, have the appropriate response to the vaccine, it may be a question depending on what kind of immunosuppressive therapy they're on. But I don't think there's any harm in getting it.
So yeah, we're not talking about in lieu of acyclovir.
Right.
We're talking about in addition to.
Yes.
Dr. Lentzsch, where does Columbia stand?
Absolutely. I agree. I recommend that to my patients. As Cara pointed out, I think it's important that you get the Shingrix at the time you can really build up immune response. We know that with Dara, it inhibits really the response to vaccinations, similar to COVID vaccines, for instance. So get it before, at the time you do not get steroids or CD38 antibodies, daratumumab. But again, you should get it, but it does not substitute antivirals, acyclovir, for instance, when you are on a proteasome inhibitor.
Okay, great. Okay, now we're still in the proteasome inhibitors, and we've discussed bortezomib and carfilzomib, His, and ixazomib, Ninlaro. Okay, so now I see 2 things on here. Merism. Oh, by the way, Dr. Lentzsch, what does the MIB mean at the end of all of our proteasome inhibitors?
For me, that's a proteasome inhibitor.
So in other words,
the MAP is a monoclonal.
know.
And the MAPs are the monoclonal antibodies, isatuximab, you can see that, antibodies, you see daratumumab, isatuximab, elotuzumab, the MAPs are all the monoclonal antibodies, and the MIPs, that the proteasome inhibitors, and the mites are the IMIDs, thalidomide, lenalidomide.
right. So in other words, but we can't break down that MIB. We know that the I would likely be inhibitor, but we don't know what the MIB means, right?
That's a good question. I don't know.
Jeopardy, Muriel.
We're going to find out.
With these questions.
We're going to find out one of these days. Okay.
I don't know.
So let's get to what is merizumib and oprozumib. Should we know about those? Are those being given to amyloidosis patients? Are there trials for them? Dr. Rosenbaum.
These must have been on the list for a long time because there were times where we even studied this 10 years ago. And, in myeloma, I'm not aware of it being studied in amyloid. I don't know where. I think that these have been on the list to be inclusive of proteasome inhibitors, but they haven't really, they haven't made it into frontline of really any plasma cell treatment. So I guess we can keep them, but there were other proteasome inhibitors. Reprosamib was an oral that there are a lot of different trials that went on and to try to see if it was tolerable. And I don't know the latest on that because it's fallen off the radar for me.
Okay, so Dr. Lentzsch, do you think we should take Merizumib and Oprosamib off our list here?
Yes, you should. I don't even know that Sloan are tested in multiple myeloma. For sure, I'm not aware of any clinical trials in amyloidosis. I don't think so.
Yeah.
Dr. Dember, do you know anything about these two guys here? No?
No,
Right.
I don't know.
They're leaving the list. Good. We need more room on the sheet, right? Okay. Let's move over to steroids now. Dexamethasone, okay, which we discussed briefly as part of the CyBorD, Dara, and prednisone. And something we're hearing about now, we're hearing that people in the hospital with COVID are being given dexamethasone or prednisone. So that sounds like, and it seems to be helping people. So Dr. Rosenbaum, we know why let you tell us, why are people given dexamethasone along with all these other drugs in the CyBorD regimen?
So it's very different than patients getting a course who have COVID, different rationale. They're getting daily steroid. We give it I describe it as primarily another drug against the plasma cell. We're giving it in a pulse dose. Amyloid cells, plasma cells are very responsive to steroids, especially if they're active, you have active disease, it's growing. So we give it like that. Now it can be synergistic with other, drugs, meaning that it can help those drugs work better and vice versa. We see that mostly with IMIDs. Most of the data is with IMIDs. And for our amyloid drugs, we haven't even gotten to IMIDs yet. With Velcade, I don't have data where it specifically helps the Velcade work better. Where I have seen it help with Velcade is that it helps reduce injection site reactions. If someone got their Velcade and they didn't get a steroid without it at all, they may have more risk of having a small wheal. I don't know if a synergistic effect, there may be, but not as strong as with IMIDs. And then, we don't know some of these other new drugs coming out if there's really a help with the steroid at all, like in terms of our new immunotherapies. So I think it's going to be an important part of each study and to look at the dosing of how you would dose that in terms of it being helpful as an additional agent against the plasma cell. I mean, you can give steroids alone and someone could have a great, a partial hematologic response. We usually don't prefer that the only treatment, but there's cases where someone may have to do that, or you may have to do that for a few months, and it works very well. So, yeah.
Well, I read recently, and I don't remember where I read it, that an article that said that patients, that physicians should, rather than treating people right away with CyBorD and daratumumab, they should hold off on the dexamethasone as a first-line treatment, and why, or cut the dosage. Dr. Lentzsch, why would that be?
I'm not sure that I agree with that statement. As a physician, our primary goal is to bring amyloid patients into a complete hematologic remission. That's the highest priority. We know that only when you reduce the light chains, you can allow the body to break down the existing amyloid. So I'm not sure whether we are brave enough to omit in the beginning of the treatment a drug that is very potent. To be very honest, I wouldn't have the guts, and I'm not sure whether I would support a clinical trial that would test a non-steroid regimen versus a steroid regimen. Sometimes we have to do that in patients with advanced heart failure. They basically do not tolerate the steroids, and we have to cut it. But to omit this from the beginning, I think it's too critical to induce the fast response in amyloidosis. You can do it in multiple myeloma, where it doesn't matter whether you achieve a remission 4 weeks earlier or later, to say that a little bit lacks. But in amyloidosis, I think it's, and Matt Mara, you know him so well, Muriel, and we take our amyloid patients as almost as emergencies, as a hematologic emergency with starting right away. So again, I'm not brave enough to omit dexamethasone that has side effects. It's an ugly drug for our amyloid patients. I know patients hate it, but sometimes I say, let's focus on what is really important. And if you can tolerate it for at least the first couple of weeks, let's give it a try.
Thank you. We've been joined now by Dr. Heather Landau. Dr. Landau, I don't remember where I read this or whose study it was about, cutting down the dex initially. But what are your thoughts on that?
I mean, cutting down, sorry, is different from cutting out.
Well, it was European, okay, that I remember, and it was this week that I read it. And they said it reduced mortality. It might have been a retrospective study too. I honestly don't remember. But Dr. Landau, are you with us?
Yes. Hi. Do you hear me?
I hear you. Yes, and we see you.
Oh, you do. Okay.
So the initial cutting down or leaving off dexamethasone for a while. What are your thoughts on that?
Right. So I feel the same way. I mean, as Cara said, and as Suzanne said, Dr. Lentzsch said that it's an important drug for it's an important drug in our armamentarium against the plasma cells. I do often, and in our initial therapy, which most of us have adopted as daratumumab plus CyBorD, it's imperative that we use dexamethasone as at least as a pre-med for the daratumumab in the at least in the initial 2 doses. So I often use dexamethasone with the first 2 doses, and then I often cut it down because of the side effects of fluid retention, insomnia, mood swings, and all of the other immunosuppressive characteristics when we're using it with such a potent regimen. I wouldn't say omitting it up front makes a whole lot of sense for a variety of reasons, but cutting it down to tolerable levels when we have very active therapy is my bias.
Dr. Dember, we know that dexamethasone, because one retains fluid with it, it can be hard on the heart. Does it also have an adverse event with the kidneys?
It doesn't directly harm the kidneys. As you said, it causes a lot of fluid retention, which can be a very big problem in people who have amyloid kidney disease, amyloid involvement of the kidneys. So it can be a hard drug to use. It can make symptoms worse, but it doesn't make kidney function worse. It doesn't reduce the clearance function by the kidneys.
Okay.
And just to bring this outside of the realm of amyloidosis a little bit, steroids, glucocorticoids, which dexamethasone is a glucocorticoid agent. They're used very frequently for people with kidney diseases, other types of kidney disease. And I think most patients don't like them, and most physicians have kind of a love-hate relationship with them because they can be incredibly effective, but as people have said, they have a lot of side effects, and patients don't generally like them.
Okay, thank you. Just before, we're going to be discussing Dara and the antibodies, the plasma cell antibodies next, but before we do, since this is a good segue, because Paula has some information for us on financial help, one of them being financial help for those on daratumumab. Paula, are you ready to share that with us?
Yes, ma'am, I am. And how about this girls only panel we got going on here?
Yes.
Yeah, girls rule.
Yes, Bob, do not show your picture. We don't want to see you.
And as I wait for him to get the slides up, The drugs that we use to treat amyloidosis, we all know, are quite expensive. And there is some assistance out there available to certain folks. Bob, do I have my slides?
He's mad at us because you said women only panel, and he's not going to do it.
There we go. Thank you. Okay, right now there are 2 funds that are open for AL amyloidosis, but you have to have myeloma along with it. That is the one bad caveat that goes along with this. But the Leukemia and Lymphoma Society, their fund is still open for the year, which it could close at any moment. I mean, we're well into the year, and these funds do tend to run out of money. So check to see if you qualify for it. If you do, jump on it, go ahead and get signed up for that money now, because you could lose it. It could be gone next week. The funds could be closed up. But you'll see that the AL and the MM pay up to $11,000 per year. The AL, and if you have WM along with it, Waldenstrom's macroglobulinemia, you can get $7,500 per year. Patient Advocate Foundation, they also have a myeloma only fund open. Now, the Patient Advocate Foundation will allow you to make up to 400% of the poverty rate level. You can make that amount per year. Oh, you'll see that on the next slide. The Leukemia and Lymphoma Society has a 500% threshold on that. So you can make roughly $80-something thousand for a family of 2 people and be able to qualify for these funds. They will help pay for your medicines. If you are, say, on COBRA insurance right now, it will pay your premiums for COBRA or just your regular insurance. Any type of Medicare, any type of premium, it will pay. For those of you that are on daratumumab, you can contact Janssen to see if you qualify for their financial assistance. Now, if you are on Medicare, you probably would not qualify for a copay card through Janssen, but you might qualify for any foundation assistance they have from their uninsured side or underinsured side. You can contact those. Next slide, please. This will be the threshold chart where you can get an idea. You see over here on the left the number of people in your household, and I have adjusted the columns to show the 400% or 500% levels. So you can make $87,100 to qualify for a family of 2 for the Leukemia Society, is $69,680 for the other fund. If you're in Alaska or Hawaii, you can see you have higher amounts for that because the cost of living in those states is so much higher. They make that adjustment for that. Next slide. These are some of the copay foundations that can help assist. Right now, all of these are out of funds for the year, but at the beginning of each fiscal year, they will renew these funds and put money out there. It is best for you to go to these sites, see if they have a way that you can sign up for a wait list. Go ahead and get on the wait list where they'll possibly notify you when these funds come open, or you can go to the next slide, please. You can sign up for the Penn Foundation. They have what is called the Fund Finder program that's built into their website. If you join this program, sign up for it, you put down that you are looking for assistance with amyloidosis. It will then alert you whenever any of these funds over here on the right-hand side open up. Now you can see the only one right now with a green padlock that's open is the Leukemia and Lymphoma Society. That shows they have the funds available. The other one is not covered on here because it's myeloma only, because I had put in for amyloidosis. So that's why it's not showing up on there. But all these other programs are closed right now. But if you sign up for this app, it will tell you, it will send you a text when they open up, and you then know to apply for that now. Don't wait around. Like I said, even with the beginning of the new year, I've seen these funds stay open possibly a week, sometimes longer. They may be open for a week, 2 weeks, and then close and then reopen again at some time throughout the year. Just go ahead and sign up for those text alerts, and you'll get them when those funds open back up. I wish everything paid for AL only, but it doesn't. The HealthWell Foundation does have a fund though for AL only. So keep that in mind, and be sure to sign up for the HealthWell Foundation if you have AL only without myeloma, so you can possibly get on their list and get some assistance with your copays this next fiscal year. So just know there is some assistance out there. Be persistent with it, stay on top of it. And if you find out there's money available, be quick and apply. That's all I can say about that, is be quick. But I thank you very much for your time, and I hope you find a fund that might help you.
Thank you, Paula. That was so helpful. If you have any questions about these funds, or you have a problem with it, Paula will help walk you through it. I've seen her do it for other people before. Just send an email to Paula at amyloidosissupport.org. She's super helpful. We recently had a webinar for insurance and Medicare, and if you did not have a chance to watch that, you can see it on our website and on our YouTube channel, and people just really enjoyed that, and know that all of our previous webinars can be seen on the website.
And I will also be posting the links in the chat here for all of these websites. So you can copy them and paste them somewhere on your computer, so you'll have those links handy too.
Thank you, Paula. Okay, so Dr. Lentzsch, Dr. Landau, Dr. Rosenbaum, Dr. Dember, are we ready to rock and roll? Okay, so you may demute, and now we're going to can we get back to our chart, Bob, if you're still speaking to us? We're an all-woman and one-man panel. There you go. Very good, thank you. Okay, so we covered the proteasome inhibitors, okay, and we covered the steroids, and we'll get back to the IMIDs and now just in a minute. We're going to head over to the antibodies. Now we do want to differentiate between the plasma cell antibodies and the fibril antibodies. And so let's have Dr. Landau tell the difference between those two. Who's on mute?
Sorry about that. So the antibodies that are directed against the plasma cell, namely daratumumab and isatuximab, are directed against a marker on the plasma cell called CD38. And that's directly a marker directly on the plasma cell. And so those antibodies bind to the plasma cell directly and use our immune system to clear that the plasma cells, the abnormal plasma cells, very effectively. The anti-fibrillar, anti-amyloid type antibodies bind to an epitope on the amyloid light chains, so a different target on the amyloid light chains, and again use the same mechanism or similar mechanisms to clear the light chains, which is distinctly different than clearing the plasma cells.
Right, so we're talking about the fibrils being, in other words, making the organs heal, hopefully, whereas the antibodies to the plasma cells, similar to the alkylating agents and the proteasome inhibitors, are going after stopping the factory from making amyloid in some way. So let's discuss, we discussed daratumumab. Okay, isatuximab and elotuzumab, are they, Dr. Lentzsch, are they cousins of that? Are they competitors? Are they as good? What's going on with them?
So daratumumab and isatuximab basically bind to the same target on the plasma cell. Yeah. So the plasma cell has certain, I would say, features. We say it's an antigen expression, and the monoclonal antibodies recognize that target and bind to it. And in terms of daratumumab and isatuximab, it's the same target. It's CD38. I think that the antibodies are pretty much the same. We are not able to really see the difference in terms of higher response or lower response in multiple myeloma. Daratumumab was just, I would say the first, not the first, but it was much faster in clinical trials, and we have daratumumab approved in AL amyloidosis. So that's why we don't have to fight with insurances, much easier to give it. There is, or there was a clinical trial with isatuximab in AL amyloidosis. It was a SWOG trial. SWOG is Southwestern Oncology Group. It was a phase 2 trial and was pretty successful. So I would feel comfortable to give either daratumumab or isatuximab in AL amyloidosis. But because of the Andromeda trial, we have much more data and FDA approval for Dara. So that's why I guess Dara is the winner in AL amyloidosis, and we can give it without problems. Elotuzumab is a monoclonal antibody that binds a different target on the multiple myeloma cell. We call that SLAMF7. So it might work in case CD38 is not any longer expressed. So the plasma cell is losing the marker, but still expressing a different marker that can be used as a target. So again, Dara-Isa, pretty much the same. Elotuzumab, less effective than Dara and isatuximab, but it could be used in AL amyloidosis in a relapsed setting.
Okay, so is there a clinical trial currently going on for isatuximab similar to the Andromeda trial for daratumumab?
I mean, I'm not aware that there's a clinical trial with isatuximab. The SWOG trial was closed. That was using isatuximab, and the Andromeda trial for newly diagnosed AL amyloidosis patients is also closed.
Okay, so will they be presenting to the FDA for FDA approval, or do we not know that?
No, we asked, SWOG asked the isatuximab. It was a relatively small trial. I'm not exactly sure how many patients we put on, but it was in the 50-ish. And we asked the company, Sanofi, whether they would expand this clinical trial, and eventually, but there was unfortunately not a lot of interest. Yeah.
Did you, Dr. Lentzsch, Dr. Rosenbaum, Dr. Landau, did any of you have the isatuximab or the elotuzumab trial?
Yes, I had the isatuximab trial, had a lot of patients on it, and it was very successful. We haven't published it yet, but but it was presented at ASH 2020, and the overall response rate was almost 70%.
In your opinion, would it be as good as daratumumab?
I think that it's hard to. There's been no comparison directly either in multiple myeloma or light chain amyloidosis. I think the issue is that daratumumab has now been studied subcutaneously, and isatuximab is still given IV. And I think that will, again, barring any differences in efficacy, I think that the phase 2 data looks similar to the phase 2 data in daratumumab, understanding that this wasn't a direct comparison, but the pluses and minuses of daratumumab compared to isatuximab, which I believe isatuximab is being developed as a subcutaneous formula, but as of now, getting daratumumab as a subcutaneous injection saves a lot of time when you're comparing it to getting an IV infusion. The only other, maybe something that may be more appealing to patients, however, isatuximab is given once isatuximab is the other thing that's appealing actually for daratumumab, isatuximab is given 4 weekly infusions, and then every other week continuously, where daratumumab, as we know, after 16 doses, we go to monthly.
Okay, we have someone who wrote in a question relating to isatuximab. So since you had the trial, we'll consider you the isatuximab expert for this question. Okay. My free light chains are mildly elevated and have been stable for 2+ years using isatuximab. I am fortunate that my lungs, heart, and kidney function have remained normal. I exercise regularly. However, I get very fatigued at odd times, but then my energy level recovers in an hour or so, but then an hour later or so, I am extremely tired. Sounds like me, and I'm not on anything. Okay, what could be causing this, and what can you suggest for my fatigue?
I think that's a very difficult question. I think that as long as it sounds like you're doing quite well on the isatuximab, and the my bias is to keep active and to keep exercising. And I think overall, continuing to be functional, even if that, I think that you'd probably be more fatigued if you didn't exert yourself, actually.
Okay,
I think, you will go ahead, sorry.
go ahead.
Yeah, I think fatigue it's very difficult for us. There are so many reasons why you could be fatigued. It could be amyloidosis itself. It could be the treatment. It could be age. It could be a combination. So I always have prompts to jump on the symptom fatigue. And you really try to pinpoint, what do you think? You know your body. Is the fatigue worse than it was before? Was it triggered? Is there any change? What I see very often is that patients with amyloidosis are initially so sick that they do not have to, I would say, they're not aware of the fatigue. Once they get better, they realize and expect that, I would say, the stamina they had before they became sick with amyloidosis, they expect the same stamina. So I think when you have a lot of organ involvement, there might be a baseline of fatigue which is normal. And I usually try to ask the patient to really pinpoint, is that the treatment? Is it getting better maybe shortly before you get the next treatment? Because the biggest mistake we can make is to blame a treatment that is effective and omit that treatment because there's a fatigue that has another reason.
Okay,
I hope it makes sense.
okay. We do have some interesting input from some of our people in the Q&A on the MIBs or Zomib part of the word. Okay, and so basically it seems to be that there's a Medscape website that explains MIBS and Zomib. So after this, we can all go to the Medscape website and look it up, and then okay, and we appreciate all this input. It's really great. Okay, okay, let's go over to the IMIDs. Okay, and we don't really need to discuss thalidomide because that's not used in AL amyloidosis at all. I think it might be in Europe or somewhere, but not here. Okay, so let's go to the Revlimid, lenalidomide, and the pomalidomide, Pomalyst. And I do remember, Dr. Dember, that there was some publications about kidney adverse events with the kidney with Revlimid. Can you go into that a little bit?
Yeah, this was now many years ago, but when lenalidomide or Revlimid was first being used in AL amyloidosis, it already had been used in myeloma. We were just sort of noticing, anecdotally and taking care of patients that a reasonable percentage or a concerning percentage were developing worsening of their kidney function while they were on the drug. And it seemed in many of them to reverse if they came off the drug or stopped it for a while. So we just reviewed kind of all of the Boston University experience. I was in Boston at that time with the drug and did find that about 25% of patients who were getting lenalidomide who had AL amyloidosis, this is different than the myeloma experience, I think, had a worsening of kidney function. And in many cases, it would get better. In some cases, it did not. And they progressed, to dialysis dependence in a relatively small proportion, but it did happen. And we published that. And, at first, I think there was some skepticism about it because that really was different than the experience people had using this drug in multiple myeloma. And so we thought, well, is it only in people who have kidney involvement with amyloidosis? Are they susceptible to this toxicity? But it didn't seem like it was exclusive to those who had kidney amyloidosis. Since that time, I think others who use the drug have seen the same thing and see that some patients do get worsening of kidney function on the drug. So I think it's something to watch for when patients get started on lenalidomide, particularly patients with AL amyloidosis, because they do seem to be more susceptible to this. We don't really know the mechanism. There, again, haven't been large biopsy studies, so we don't really know what's going on at the level of the kidney. But I think it's real. It doesn't seem, and this is not a carefully done study, but it doesn't seem, and others on the call probably have more experience with pomalidomide than I do, but my sense is it doesn't seem to happen as often in AL amyloidosis with pomalidomide as with Revlimid. The other thing I would say about about Revlimid in particular in people who have kidney impairment, who start out with kidney impairment is, the dose needs to be reduced, the toxicities, fatigue in particular, I think can be worse in patients who have kidney impairment, and so the dose often needs to be lower.
Okay, so we'll start with Dr. Lentzsch and then go to Dr. Rosenbaum and Dr. Landau about Revlimid and pomalidomide and adverse events. Do you see these kidney adverse events, and do you also see cardiac adverse events, Dr. Lentzsch?
Yeah, I mean, I have to say, I'm not sure that I recall really saw increase in GFR or worsening of the renal function. I use IMIDs very limited. It's not tolerated in patients with AL amyloidosis. If I have the choice, or if I do not have another choice, I would rather use pomalidomide over lenalidomide. I have to say that I have several patients who came to me on RVD, and they felt awful. They were not functional. They kind of really did not tolerate.
RVD would be Revlimid, Velcade, and dexamethasone, right?
RVD, exactly. Revlimid, Velcade, dexamethasone. In principle, you replace the cyclophosphamide by the lenalidomide. And they felt horrible. They were not functional. They were in a wheelchair, basically. And all what I did is I stopped the lenalidomide, and they improved substantially. They said, my goodness, that's a miracle. What I have to say, despite they felt much better, very often we see that those patients go into a deep remission. So in principle, lenalidomide is working in AL amyloidosis, just the patients do not tolerate that very well. And let me just kind of, bring one comment. There was a study or a retrospective trial by Dr. from the Heidelberg German group, Dr. Schönland.
Oh.
Schönland, yeah, exactly. I think they looked in their own database and they analyzed a large number of patients with AL amyloidosis receiving lenalidomide, and the results were really not very good. A lot of patients, around 20%, had worsening of their heart failure. So based on that retrospective trial, I have a slide on that. They really, I would say, said, you have to use it judiciously, So it's not my favorite drug in AL amyloidosis, and I use it only if I have absolutely no other option.
What about pomalidomide?
Maybe I'll just, sorry.
Oh, I'm sorry.
Well, I was just going to jump in and say that at the time that we did this, we looked at this experience. It was before actually bortezomib was being used. So there were many more patients who were getting Revlimid at that time than I would say with AL amyloidosis than there are now. But I would agree that, and we would all, even if people didn't have renal impairment, the dose, I think, of Revlimid in AL amyloidosis needs to be lower than it is in people who have myeloma. So, instead of starting with 25, the dose may be 10 milligrams. And if they have renal impairment, it may be 5 milligrams. So I think it is really hard for amyloidosis patients to tolerate.
I remember that study was like 2004, 2005.
Yeah, it was a while ago.
Yeah, a few years ago. And I remember Mayo put out a study at the same time and with very similar, results that BU had. Dr. Rosenbaum, what are your thoughts?
Well, I agree. I think it needs to be used selectively. I think that's the word, because we know it works. We know at the right, the approved doses, at least in myeloma, and even in lower doses that have been studied in amyloid, for instance, 2 milligrams versus 4 milligrams. And we know that these drugs work. A lot of these trials, they're not compared to other regimens we use currently in terms of randomized studies. But looking at them, I've had patients who've had, just as good responses on IMIDs as, they did on Velcade. Again, these are when we were using more single agent Velcade before we had Dara. But I think we get into problems first with doses for any patients with, or any moderate to severe organ dysfunction. But a lot of our patients they may have mild organ issues, but they still have amyloid, they need treatment. Also, they may be relapse. We use these drugs in relapse disease. We don't often use them frontline. And I think the point in relapse is that a lot of patients, not all, are doing quite well at relapse. Usually nowadays much better than they did at diagnosis. Their organ functions may be better. They may have already had a transplant. This may be years after. And we also, if someone is treating them when they first see their light chains rising, like in a biochemical relapse, not everyone does that. But if your patient had very severe organ disease in the past and you're going to treat them at very early, the patients may be asymptomatic and be in a very good place to tolerate these drugs. And I think that's a setting where I've used it more because most of the patients have already had Velcade, they've already had Dara, so I don't think we should just completely say these are out the window. But I think selected, anyone with severe kidney dysfunction anytime, or, any severe heart failure, it's going to be harder to tolerate, and you're going to have to use such low doses that they're very likely to be ineffective at those doses.
And Dr. Landau.
So I share my colleagues' sentiments, and I think that, the one thing that we have to understand is that lenalidomide, Revlimid in the phase 1 study in AL amyloidosis really was the maximum tolerated dose was only 15 milligrams. So they can't be given at the same doses as we give in myeloma patients. And that's, I think, where I share Suzanne's sentiment that patients often come to us being treated in the community as myeloma patients with amyloidosis, and they get full dose Revlimid, and they really have a very difficult time. Even 15 milligrams can be hard, and as Dr. Dember said, we often start at 10 milligrams of Revlimid in our patient population. But still, the one thing that we have to recognize is that the IMIDs also cause the cardiac biomarkers to increase. And this is a phenomenon that's not well understood, and it can be associated with cardiac toxicity. So we have to watch that closely. Again, as Dr. Rosenbaum said, these drugs can be effective if they're tolerated. And again, I often use them in combination with daratumumab. So a small dose of lenalidomide with daratumumab, or a small dose of, my favorite approach would be pomalidomide, which I think is better tolerated than lenalidomide in amyloid patients and with daratumumab. But you also have to watch the blood counts in that setting, and again, the cardiac biomarkers.
Okay, so we've pretty much discussed the IMIDs. I think, we should even remove thalidomide from that. I think that's confusing. I think we should just take that off that column because it's just not used in the United States. Okay, so let's move over to the novel agents, okay? And so right now we have a novel agent, although we might be adding to that, okay? And that's Venetoclax. So let's start off with, well, let's stick with you for a second, Dr. Landau. Do you have a Venetoclax trial going, or do you ever use it? And when do you use it?
Yeah, so Venetoclax is a new newer in terms, it's not yet approved for multiple myeloma or light chain amyloidosis. There have been studies in myeloma, particularly it's effective against patients with translocation with a cytogenetic abnormality, translocation 1114, which is less common in multiple myeloma than it is in AL amyloidosis. And we see it in AL in about 50% of our patients. And so since this agent is very effective against that subtype of AL, subtype of myeloma, it's been studied in, it is going to be studied prospectively, but there has been at least a few retrospective studies published. Suzanne was the first or the senior author, and it is seemingly very effective, especially against the translocation 1114 subtype of AL amyloidosis. It's an oral drug, it's well tolerated. I have used it off-label, and it can be very effective for our patient population. So I think it's an emerging drug, I would call, in this disease. There has been some holdup with the prospective clinical trials because I think it is also immunosuppressive. And so in the studies in multiple myeloma, although in the translocation 1114 group, this was very effective and prolonged progression-free survival in all comers, meaning in the patients without translocation 1114, despite a progression-free survival benefit, there was some question about overall survival. Namely, there were in patients who were sick with myeloma, who were put on this drug, had a worsening of overall survival. So the FDA has been highly regulating the prospective studies, very selective or in terms of what studies are moving forward in patients with AL.
I know that Dr. Comenzo had the first trial that I'm aware of with Venetoclax, and we're also aware of quite a few patients who, after trying everything, they seem to say, "Oh my goodness, I'm on Venetoclax and it works. It's the first drug that's worked on me." So, Dr. Lentzsch, what do you have to add on the Venetoclax?
No, Dr. Landau summarized that really, I would say, perfectly. That doing the clinical trial in multiple myeloma taught us two things. Number one, the drug showed exceptionally responses in patients who have a certain mutation, translocation of their genes. So with the translocation 1114, we saw that those patients had an outstanding overall response rate. What we also observed was that suddenly, even if the patients were responding, they didn't live longer because they died from complications such as infection. So that was a downside. But that is a different story in multiple myeloma, as patients are much more pre-treated. I mean, they have 5-6 lines of treatment. We don't have that in amyloidosis. So what we thought, and again, Dr. Comenzo was one of the first ones who said, okay, if it works in translocation 1114 in multiple myeloma, and we see in the relapse setting up to 60% of our amyloid patients having this translocation, why are we not using this? And I would say Dr. Comenzo and then subsequently other physicians around the world used Venetoclax, which I think in the beginning was very hard. We couldn't get it approved from the insurances. It wasn't even approved for multiple myeloma. It was approved for it is approved for CLL. It's still not approved for multiple myeloma. And I remember that one of my first patients paid $7,000 a month for Venetoclax. The beauty was it's working, and I mean, I rarely do this, but I have so many fights with our pathologists right now because they always come back and say, oh, we couldn't do the FISH or we didn't have enough cells. So I encourage every amyloid patients, look for your translocation 1114, ask your doctor. If you have it, then I think Venetoclax is an option a very potent option. And I saw patients resistant to daratumumab, Dara-CyBorD. I put the patients on bendamustine, nothing worked. And then I put the patients on venetoclax, and it's just kind of, amazing what you see. Even in a very low dosage, so multiple myeloma, we gave 800 milligrams. In amyloid, you don't need that much, because remember, you don't have a cancer in general. It's just an MGUS. So 400 milligrams of venetoclax, no ramp up doses, so you do not have to start low and go up with a higher dose. You can just give 400 milligrams, single agents. Very often I give it without dexamethasone, so it's beautiful. And it will be a game changer, and I see it up front in translocation 1114. Sorry, Muriel, for being so, I would say, excited, but it's a great drug for amyloids.
We love it. Okay, Dr. Rosenbaum, do you have anything to add to that?
I really don't have much to add. I mean, in general, this whole class is exciting, and there's not anything we can talk about today, but there's even newer, either novel BCL2 inhibitors in amyloid that hopefully will be studied. So I think in the next few years we'll see a lot more with this entire class. I think we should change the title "Novel Agents" to BCL2 inhibitors.
Yeah.
Okay.
Yeah.
Okay, good. Okay, thank you. Okay, that's wonderful. Okay, so we have a break scheduled here, and I really need it. So so therefore, we will take a 5-minute break, okay? And then we'll be back to discuss all the antiviral antibodies. We'll be discussing stem cell transplants. We'll be discussing doxycycline, CAR T therapy. So a lot more to come in 5 minutes, okay? We're so grateful to all of our doctors for being here today. Obviously, there were a lot of other things going on today. So we invite, if you're wondering, why isn't this doctor here? Why isn't that doctor here? They were all invited, okay? And some said yes, they would be here, but unfortunately in the last minute, they were pulled away by something else. Some were pulled away, but were able to come back to us. Some told us up front they weren't going to be able to make it, but all of them wanted to be here and know that. That's really important. They all wanted to be here. So, and they will be at future webinars, so not to worry. But I think our panel today, our power panel, is doing quite well, and we're extraordinarily excited. It reminds me of our live meetings in New York when we would have the same group of people, and it brings back wonderful memories, and hopefully the future will look that way too. Okay, now we're going to discuss we're going to discuss the CALM trial, and there's going to be an upcoming Proteasome trial for removing the amyloid fibrils from the organs, from the heart, the kidneys, wherever they are. And we see that the GSK trial is crossed out. That's because the trial proved to be, well, I'll let Dr. Rosenbaum, why don't you tell us why the GSK trial was crossed out?
So, this goes back to it's a saga now. In general, we have these 3 drugs you see here. We won't go into all the historical information, but the GSK trial was one of the, like the other antifibrils, one of the exciting new antifibril drugs. It worked slightly differently. It was given slightly differently. And the trials, there weren't as large trials in the US as we had with any NEOD 001. So that may be why people weren't as familiar with it. But unfortunately, we heard rather suddenly, I remember it was a sad day that, there were toxicities seen in the study, and the trial had to be closed. It was closed down. So, I don't have any more confidential information than that, but it was, there were concerns with infections, and so I have not heard that this drug is going to make a comeback. It would be great if it could. So we'll have more options for this class. I don't know if anything more to say about that.
Right. Now I know that was going on in the UK, and I remember after they closed down the trial, Sir Mark Pepys, the originator, the founder, the inventor, he had said that he didn't think it was a dead issue, that I don't know if it's he wanted to continue or if it is continuing in some way that we don't know about. But for all intents and purposes, it's not active right now. So we've
Muriel,
got,
could I just make one point?
oh, absolutely.
It may just be, this is just for educational purposes, really, just to point out that the GSK monoclonal antibody is directed against, unlike the other agents, it's not directed against the light chains, it's directed against a protein that binds to all types of amyloid, the SAP protein. And so, one of the disappointing things I think about that trial being closed down is that this drug or this agent potentially could have had benefit in all types of amyloidosis, not just AL.
Very good point. And then that reminds me that Dr. Jonathan Weill at the University of Tennessee is working on a new, he calls it a peptide, I guess. I'm not a scientist or a doctor or anything even close, so I don't know that much about what a peptide is. Perhaps you guys can explain it to us, but he's working on something that will also work on all types of amyloidosis. So can anyone fill us in on how that's going with Dr. Weill at Tennessee? No? Okay, well, we'll find out more.
I think, Muriel, I think he's using 11104 and tries to enhance binding of that antibody to amyloid and is using that little peptide, a piece of protein as a better linker, that antibody. And I think the advantage of his efforts is also that you could use it as an imaging agent. So I think he has a company to use it as an imaging agent.
Right.
But I don't think clinical trials. I think this is really preclinical work.
Right, and I think he's pretty much shut down the imaging study for now. I think he's had enough people, both in AL and TTR and other types of amyloidosis. So I think we'll see some results published on that. I know we've had him as a guest at a lot of our meetings, and he's given us some really exciting data from those studies on the imaging. And some of the people that are tuned in today have probably taken part in that, which is pretty exciting. Now people are kind of frustrated. The CALM trial is for newly diagnosed patients only, and very likely the Prothena trial for tamimab, which we knew as NEOD, will also be for newly diagnosed patients. But we also realize that it has to be newly diagnosed patients so that you can show the FDA a clean trial where hopefully they'll show a clean trial. But what do all three of you have the CALM trial going?
We do. We opened it about a month ago.
Okay, and Dr. Landau, do you have it going?
Yes, we just opened it as well.
And Dr. Lentzsch?
Yes, it's open at our institution. Yeah.
Okay, so you're kind of the birthplace of the CALM trial, aren't you? You had that first.
Right. Yeah, but exactly. I mean, I want to point out that first of all, I want to make sure that everybody is aware that I have a conflict of interest here. So I can only give very general information. And I'm not involved in the clinical trial because of that conflict of interest. But I want to point out that KL101 is an antibody that was, I would say, originally invented by Dr. Solomon, who is, one of our, not grandfathers, that doesn't sound nice, but our founders of the modern treatment in amyloidosis. And that we did the first clinical trial here at Columbia. And like NEOD-001, right now it's tested in advanced stages of AL amyloidosis. And I know that patients are disappointed, and very often they say, why is it, tested only in late stages? It might work in early stages much better when you have to, or when the antibody only needs to remove small amounts of amyloid. But that's something by the FDA, that the FDA required, that overall survival benefits should be shown. So that's why, if you ask me, my dream trial would include all amyloid patients, but unfortunately, that's not always possible.
I want to take a step back to the Venetoclax for 1 minute. Dr. Landau, one of our patients asked a question. They want to get checked to see if they have the translocation 1114. What kind of test would that be?
So translocation 1114 is a marker in the actual plasma cell, so it's a cytogenetic marker that we can only test in the bone marrow. So even if you're in remission now and we did a bone marrow, we might not be able to detect it, but translocation 1114 is present from the time that the disease starts. So even if you have a bone marrow that was done at the time of your initial diagnosis, if you have translocation for 1114, that should be able to be detected.
So would they go back and look at that?
So it's by a test called FISH, which is fluorescent in situ hybridization. So on your original bone marrow, they should have done a FISH test, and that's where you'll find that translocation 1114. If you have relapsing disease and you have plasma cells in your bone marrow now, then you could also do a bone marrow test and ask them to do the FISH. There are ways to, even if they didn't do the FISH initially, that they can do that on archive samples sometimes.
Okay, so they saved those samples when you were first, if I was first diagnosed by Dr. Know Nothing in Podunk, Iowa, he would still have those initial samples?
I would hope so.
Okay, great. Okay, now getting back to the CALM trial. So Dr. Lentzsch kind of, has a conflict and she can't tell us a whole lot about it. And Dr. Landau and Dr. Rosenbaum, you've only had the trial a short time. Dr. Rosenbaum, how many patients do you have in that trial?
So 0. We opened, but the issue is it's not all cardiac amyloid patients. It's stage 3A and 3B. They're two separate trials actually. So we had a stage 2 who didn't make it. I mean, like the patient was so disappointed. We tried our best. And they, it's really strictly for the really advanced. So I think the enrollment may be a little slower because of that, which is why it's being opened up. So, internationally, a very large number, but I mean, you don't really know. No one knows their stage and it can change quickly. So I would encourage all patients to, really be on top of that. Not get disappointed if initially they get a lab, a month later, it could slightly be different. They should just talk to their doctors who have the trials open.
Right, of the people that are tuned in today are probably already on treatment, but and this is one of those cases where people want to be a little bit sicker than they are just to qualify for the trial. Dr. Landau, how many people do you have in the trial?
Yes, we have the same issue. We just opened, so we don't have anybody yet. Again, it's a very selective population. Such that I think it's the very advanced cardiac patients, and sometimes those patients are diagnosed elsewhere, and so they have to actually get to a center that has one of these trials. But I would encourage anybody who is newly diagnosed to be screened first for this trial. I think it's a very important trial. Fortunately, I think we will have a CAL 101 containing trial in the next several months for patients who are relapsed, and a broader eligibility for the upfront setting, hopefully.
So that would be similar to the Pronto trial that they had for NEOD back in the day when previously diagnosed patients were able to get on it.
Yes, we're actually doing it with isatuximab for relapse patients.
Oh, very good. And okay, so I think no one has typed in any new questions on this, so I think we can move from the fibrils. Okay, and so Paula was talking about financial aid for people who also had a diagnosis of multiple myeloma. And we see two different things here. We see patients, well, actually three, and in our meetings and in our Facebook group. We see people that have the diagnosis of multiple myeloma, but they don't really have multiple myeloma, but they have 10% or more plasma cells, and their doctor says they have multiple myeloma. We have other patients that would qualify for the diagnosis of multiple myeloma, having 20 or more % plasma cells, but they're not given the diagnosis of multiple myeloma. And then we see patients that have real multiple myeloma and amyloidosis with all the crab symptoms, as well. So I'd like to, we'll take each one of you individually and ask you, what do you consider what criteria do you look at for your patient to be considered having multiple myeloma? Dr. Lentzsch?
Yeah. So one category is pretty easily to determine. If you have CREB criteria, for instance, especially lytic lesions, then clearly you have multiple myeloma with amyloidosis. You have multiple myeloma, but unfortunately your light chains, mainly kappa, they are sticky and they form, in addition to giving you multiple myeloma with destroying your bones, also the other diagnosis of AL amyloidosis. Usually those patients do not have a similar, or those patients have a similar prognosis to multiple myeloma, or maybe even worse if they have advanced heart amyloidosis. The other group of patients, the amyloid patients without CREB criteria, and again, I think we mainly talk about lytic lesions because increased creatinine can be easily due to renal involvement in amyloidosis. And I would say hypercalcemia, for instance, the CREB criteria, that is more multiple myeloma associated with bone disease. So if you do not have any bone disease and you have maybe 20% plasma cells, for me, it is still AL amyloidosis. I talk to my patient and say, if you see the diagnosis of multiple myeloma somewhere in your charts, I have to use it for insurance purposes, to be very honest. But I try to explain the patient that in my eyes, you truly have AL amyloidosis with a higher grade plasma cells. And we usually see that those patients do not as well as those ones who have 5 or 6 or less than 10%. But for me, they are truly AL amyloidosis. And I do not call it multiple myeloma. That's what I do, regardless on the plasma cell, I would say, number in the bone marrow. And I don't think that there's any definition or cutoff when we call it multiple myeloma or AL amyloidosis. I think that's a bit arbitrary what we do.
Dr. Landau?
Yeah, so I agree. I always explain, I mean, we categorize multiple myeloma by its end organ damage, right? So we say that patients have active myeloma when they meet definitions for the CREB criteria, meaning their kidneys are involved or they have bone lesions or anemia or high calcium. Now we say that they active myeloma is defined by their end organ damage, and similar, symptomatic light chain amyloidosis is defined by its end organ damage. So if you have greater than 10% plasma cells, but all of your end organ damage is attributable to amyloid deposition in your organs, I say that you have light chain amyloidosis or primary systemic amyloidosis. If you have also myeloma defining features, then you have myeloma with amyloidosis. But by virtue of just having greater than 10% plasma cells, you don't have myeloma with amyloidosis unless you have end organ damage attributable to myeloma and amyloidosis. Does that make sense?
It does make sense.
But again, like Suzanne said, before we had an approved drug, I would say in my documentation, MM plus AL, and I would put 10%, greater than 10% plasma cells. So you understand that this is a categorization, not, for documentation in order to have them be eligible for other drugs, but not necessarily for that, because I believe they're multiple myeloma. Again, it's important for people to make this distinction because patients with amyloidosis, again, tolerate drugs at different doses, different schedules. And I think that if you categorize everybody with greater than 10% plasma cells as multiple myeloma with amyloidosis, you can use drugs at the wrong doses and treat patients with triple drug therapy, RVD, which really has never been studied in amyloidosis at the approved doses for multiple myeloma, and patients really do poorly.
Okay, and Dr. Rosenbaum?
I just wanted to bring up two kind of smaller points. One more like logistic to affect patients. I don't know if this was previously said that, you know, the majority of patients are going to have what we classically call de novo amyloid. They do not have underlying myeloma, and amyloid developed, you know, in the late stage of their myeloma disease, or they didn't have, you know, the bone issues and that we see with myeloma when they're diagnosed. But the majority of patients won't have that. However, you know, I think financially there are a lot of, you know, with not just with being eligible for trials, but also for you know, funds and getting grants. I think I would just say work with your doctor, because, you know, they can describe it accurately in a way that it can be helpful. Because in the end, I think these categories, you know, when I have a patient who has more plasma cells in their bone marrow diagnosis, even if they don't have, you know, let's say they don't have a huge lytic lesion on an X-ray. I mean, we're finding bone disease at such low levels now on MRIs and myeloma. You know, we're not doing those studies as much for amyloid patients, but we still know that they have a more proliferative disease, and that may, and we know that those patients may have to be treated more, you know, aggressively, we like to say, but just watched closer. Maybe they're going to stay on treatment a little longer or want to have a better response. And because, you know, if their disease comes back, we know their clone has the capability of making more plasma cells. Now, that doesn't necessarily equate to worse organ disease, because we know that, you know, everyone's amyloid light chain, you know, or amyloid protein is unique, and that someone can have a generally higher level or lower level, and it doesn't always equate to how, you know, how sticky it is in their hearts. Usually it does. A higher level, we know, is even in the prognostic criteria, as we have to watch these patients closer. But you know, I don't remember why I even got into that, but I think that they should, you know, work with their doctor, knowing that these labels may have effects in terms of getting drugs with diagnosis and getting grants, but in terms of how we treat it, you know, there may not be as clear differences, apart from not the doses you're using and the treatments, of course, but just work with your doctor.
Yeah, and we should point out that, you know, if you look at this chart, every single drug on there except for daratumumab is prescribed off-label for amyloidosis patients. None of them are approved for amyloidosis except daratumumab. So what's confusing to me is when daratumumab was approved, it was approved with the use of CyBorD. Yet none of the drugs in CyBorD have been approved for amyloidosis. How do they work around that with insurance, Dr. Lentzsch?
You know, what we need for insurance is an FDA approval. And nobody expected that it will be such an easy journey for Janssen, that they just go with a randomized phase 3 trial into newly diagnosed AL amyloidosis with a drug they have no other trial before. And I remember that with Heather, we went in Philadelphia. Heather, do you remember this, to an advisory board many years ago? And we tried to advise the company and said, you know, give it a try. And I have to say, Janssen was very brave just to go ahead with that trial. And they got FDA approval, you know. So the good thing is right now we can say somehow, even if we use parts of that trial, we have some data and we can go ahead and use it for AL amyloidosis. But before Andromeda, we never had problems to give Dara-CyBorD in AL amyloidosis. So usually insurance always agreed to give bortezomib or cyclophosphamide for our patients.
Great. Dr. Landau?
Yeah, so I think that that there will be, again, lots of reasons to use drugs to say multiple myeloma versus amyloidosis, but I think that predominantly the insurance approval is really the driving factor.
And Dr. Rosenbaum, would you agree?
Yes. Yeah.
And do remember, refer back to our webinar that we had a few weeks ago for insurance and Medicare, because the attorney on that webinar gave some really good advice on how to cope with insurance denials and appeals. So, and it was very interesting. Okay, getting back to the multiple myeloma issue, if someone has an accompanying myeloma diagnosis, meaning that if someone, let's put it this way, if someone has 10% plasma cells or more, do you treat them differently than if they had just the normal 5% or less of plasma cells, Dr. Lentzsch?
No, treating the same. I treat those patients the same. And you rarely have really patients, true AL amyloid patients with plasma cell infiltration rate higher than 20%. I mean, I have really few patients where I had over 50%. Remember that even if you do a bone marrow, it's not a homogeneous distribution of plasma cells. You can stick your needle into a nest of plasma cells and you might have an over-representation. So I use those patients the same, and I feel very, very comfortable with Dara-CyBorD to treat all my patients regardless how many plasma cells they have. And even if they have overlap of multiple myeloma, with a diagnosis of AL amyloidosis in multiple myeloma, I think you should also avoid Revlimid. Yeah, so that's why the initial treatment is the same. I would favor transplant for those patients if they are eligible. The only difference, where I would start to think about how I would change my management if they may be, let's say, over 30% plasma cells, are two things actually. If they have really poor cytogenetics, if we see that they have biallelic, so two alleles, so the two genes lose, for instance, the tumor suppressor gene, if we see that. And should I give those patients maintenance? That's the question. Higher number of plasma cells and poor cytogenetics, so that means a lot of mutations in the genes. Should I continue with maintenance? Usually we do not give maintenance in AL amyloidosis. In our regular 95% plasma cell infiltration and going into a complete remission after initial treatment.
Okay, so that brings up a really good point. Okay, Dr. Landau, do you treat your patients with more than 10% a little bit differently? And what about maintenance? So that's a two-part question.
Yeah, so actually, I don't treat them upfront differently. I do have a clinical trial where we're studying maintenance in patients who initially have greater than 10% plasma cells in their bone marrow, and that trial is ongoing with ixazomib as maintenance. So that trial is ongoing at our center in Tufts, trying to understand if there is, but again, there's not a comparator, so it's hypothesis generating, but it doesn't, it won't be able to say whether patients with greater than 10% plasma cells definitively benefit because it's not a randomized study. But we do have a trial where patients who have greater than 10% plasma cells are eligible to get ixazomib maintenance, understanding that in general, patients with amyloid don't typically get maintenance. And so off of a trial, I have not changed therapy for patients who changed my treatment in order for patients who have amyloid who have greater than 10% plasma cells. We know from the transplant, from the upfront transplant, before we had all these wonderful drugs, we did upfront transplants in patients with AL amyloidosis. whether they had less than 10% plasma cells or more than 10% plasma cells. And the patients who achieved the CR with transplant, many of them remain in CR to date, despite no maintenance. But Mayo did publish good data that shows that outcomes of patients who have greater than 10% plasma cells probably do have a more proliferative clone and have worse outcomes than the 40% of AL patients that have greater than 10% plasma cells probably have a more proliferative disease than patients with AL and less than 10% plasma cells. And that's the basis for our clinical trial.
Well, that's interesting. You said 40% have 10% or more. That's higher number than they used to think. Well, of course, you're seeing more patients now. You're able to really hone down on those numbers better. Dr. Rosenbaum, what about you? Do you treat the patients with more than 10% plasma cells any differently? And what about maintenance?
Yeah, it's echoing, both of my colleagues. You can't look at it like this. I mean, most people probably realize that they don't even have a number. It will say 5 to 10%, 10 to 15, 15 to 20. These are ranges. You can't, say I have 21 versus 20. I mean, that's not clinically relevant. So in general, old data showed that the average, de novo amyloid patient, their average bone marrow plasmacytosis was more in like the 6% range, and that's average. I mean, we certainly have patients who have very much lower than that, and 10% is within that range. So I think knowing the data and the Mayo, that was a retrospective look at Mayo's patients with the, who had higher risk. It's not very common to see patients over 20. So 15 to 20 is usually kind of the higher end. More than that, they do, there may be a higher rate of patients who you'll find CRAB criteria or subtle, or just a very proliferative clone, which is not, is not the common type of clone in amyloid. That's an outlier. So you will be, treating those patients, not like your general, bread and butter amyloid patient. So, it's a, there's not data that really guide us on this. It's more experience, anecdotal, some of these prognostic trials, working with your pathologist, understanding, like, I've had pathologists where it said, 5 to 10%, and then we had a discussion, we were talking about it, and they're like, oh, actually, it's more 10 to 15. These are at diagnosis, to be clear. Most of what we're talking about, the prognostic data, is from when they have that, when a patient has that at diagnosis, not necessarily relapse. Just some things to keep in mind.
Okay, well, we touched upon a subject that we want to go into a little bit further now, and that is the autologous stem cell transplant. Okay, now we've got Dara-CyBorD now, which is very exciting and brings many people into a complete response after 1 or 2 cycles. So, and we know that some people will still, we don't have any cardiologists with us today, unfortunately. They were all invited, but they couldn't make it for various reasons. But and we do appreciate Dr. Dember making it. We did invite a few other nephrologists, but they couldn't make it either. We see some people still getting stem cell transplants, getting heart transplants and stem cell transplants, getting kidney transplants and stem cell transplants. Dr. Lentzsch, now that we have Dara-CyBorD, where is stem cell transplant in your institution? Where do you see it?
Yeah, Muriel, I wish I could give you a good answer, to be very honest. On one hand, Dara-CyBorD is such a powerful regimen that many patients go into a complete remission and in principle do not need a stem cell transplant. But we have the best and the longest follow-up with stem cell transplant, to be very honest. I'm a little bit concerned that we see the short-term goal and we say, oh, you're in a complete remission and you don't need a transplant. But the complete remission might have a low quality, and we don't know what will happen maybe in 2 or 3 years. The patient might have an earlier relapse. This I don't know, but it's my concern that we achieve a complete remission, but it's not deep enough to really provide us with what we have seen with transplant. What I say is almost cure. And Heather, you will agree. I mean, you do that for many, many years. I have patients who got a transplant 10, 15 years ago with AL amyloidosis, and they are still in a complete remission. I see them as some type of cure. So I'm a little bit torn. Yeah, I don't know what the right answer is. What we do to help us as physicians to make the right decision and do not harm is that if patients are not in MRD negative, minimal residual disease negative, and they're in good shape and they are young, then we usually are inclined to do the transplant, yeah, together with a transplant and with our nephrologist. What I have to say, we learned that a little bit the hard way, and I'm glad that Laura is also on our kind of, meeting here. We are more careful with cardiology. I would say with a cardiac involvement, we have good guidance from Dr. Maura. And we didn't lose a single patient, after he said that patient is okay. What we observed was that the kidneys are quite sensitive to transplant. And a couple of our patients went to dialysis after the stem cell transplant in complete remission, but the kidneys did not survive the stem cell transplant. So we are more and more careful to really transplanting the patients who have, stem cell transplanting the patients who have advanced renal amyloidosis. And we usually don't do that if they're in CR after Dara-CyBorD.
Dr. Dember, do you see a lot of kidney failure after stem cell transplant? Not a lot, or do you see some?
Not a lot, but yeah.
Well, there definitely is some. I think the use of stem cell transplant, as everyone has said, has gone way down now that we have all these other treatments. So if you sort of had this conversation 15, 20 years ago, we tried to do a stem cell transplant really in everybody because there was no alternative. There was oral melphalan and prednisone, which was effective in only a very small minority of people. And so we were willing, if the patient was willing, to kind of take the risk that went along with stem cell transplant among patients who would now be considered quite high risk for stem cell transplant. But now the patients getting stem cell transplant tend to be the lower risk patients who don't have severe cardiac involvement, who don't have significant renal involvement. So I feel like the landscape has changed so much with the development of these new drugs. Partly because I kind of grew up in the amyloid world, I grew up when we were using stem cell transplant so much more. And I agree that I feel like we know that if you get a complete remission with a stem cell transplant, we have more confidence. And it's not true for everybody. There is a relapse rate, but I think we have more confidence that those patients will stay in complete remission than we do for the newer regimens. So I worry a little bit that we've moved too much away from stem cell transplant. But again, this is based on gestalt and experience. It's not based on direct comparisons of one approach versus another.
Thank you. Dr. Landau, do you still consider stem cell transplant in that, what they used to say, 20% that might qualify or meet the criteria?
Yeah, so I echo what my colleagues are saying. I think that we have to understand that CyBorD plus Dara has a 53% CR rate, but that's not 100%. So anybody who is treated up front with this regimen, and we're so grateful that we have it, and we're so grateful that the CR rate is as good as it is, but we also have to understand that not everybody's going to achieve a CR. And for the patients who don't, I think stem cell transplant, our goal is for complete hematologic remission and maybe even MRD negativity, and that's a whole nother topic. But the lower the better hematologic disease control, the better that our patients do. So complete suppression of the clone. And so in patients who are so our patients who are not in complete remission after initial therapy with daratumumab CyBorD, then I think those patients definitely qualify for transplant. I think it's when patients, the biggest question are patients in CR. And so again, I struggle with this because this is data-free. We really have no data to guide us. Again, and there's some data to say that patients who get into a complete hematologic remission do well, and that might be treatment agnostic, but we don't have long, we don't have, that's with very short follow-up, we don't have long-term data on this patient population. So we are stuck making decisions. And I think that for anybody who can undergo a transplant with limited risk, I would still offer a transplant. And for patients who are in CR but are at higher risk from toxicity for transplant, I often say, why don't we collect your cells and let's wait. And that may be that wait for relapse, which often in patients who achieve a CR, their organs will only improve over the subsequent months to years of them being in a complete hematologic remission, understanding that if we can collect them, then down the line, they'll have the opportunity to undergo a transplant if they need it moving forward. But I think that it's a really loaded question. We really don't know the durability of response for upfront Dara-CyBorD.
Right, we have more than 20-year data. With 1994 were the first stem cell transplants at BU, and there were 5 of them, and some of those people are still alive today. So and they all had cardiac involvement. So we have a lot of data with what's the longest data that we have with the Dara-CyBorD as far as complete response.
Patients they were on the trial maintenance for 2 years with Dara. I mean, we don't even have a good randomized maintenance data for that,
So would you say 5 years would be the maximum amount of data that we have on?
No, I didn't say 5 years. I said in the trial, the arm was 2 years of Dara maintenance monthly, but that maintenance arm wasn't randomized. We don't know.
Oh, we don't even have 5-year follow-up for patients on Dara-CyBorD.
Okay, so we have a long way to go there.
Yeah. And another point just to make is that people have used the term transplant eligible, and what's considered transplant eligible now is completely different than what was considered transplant eligible, during the era that you were just referring to, Muriel. So people have gotten much more cautious about transplant eligibility. So a lot of people who would have gotten a transplant in the past are probably not considered eligible now.
I have to say, and I'm sure my colleagues will agree, that I also, I do not want anyone to walk away from here saying, great, we don't need to transplant anymore, for so many reasons. And we don't have a way of testing patients' amyloid cells and say, what are you sensitive to? We wish we had that, maybe soon we will. But we can't tell what, and we can tell within a few doses of Dara or within a few months of Velcade if someone's having a good response or not. And there isn't any, randomized trials underway to look at this going forward when to transplant. And as Heather said, there's collections of data now, mostly Mayo, that show that delaying the transplant is safe and that the patients have the same outcomes in the short term from receiving their transplant. If they got, for instance, Dara-CyBorD up front, and then maybe 2 years later, they had their transplant, or a year later. So I don't think that's wrong. We just don't have data to know that's the best strategy. And in myeloma, the same question took years. I mean, we won't have, even if a trial was started tomorrow to look for this, we will not have that data in the near future. So I think it will still be case by case. Some patients, the very best treatment for them for killing their may be alkylating agents and transplant. And it also may be much more durable. And as you mentioned, we have no data of durability. We haven't seen someone on 20 years Dara-CyBorD. We just don't have it. And the the selection, I was going to bring that up too, that there has been even recently in the last year, there have been groups that have reported their outcomes. I think the UK had a very, very large report of hundreds of their patients and transplant. Obviously, Boston has had these reports, and each report, every 5-10 years, it's just phenomenally how much better patients are doing with their transplant. The supportive care is better. It's outpatient, for some patients. I still would like my patients to be inpatient with amyloid, but basically, I mean, the serious side effects are so low with, with again, selected patients, not everyone, but more and more patients are able to get a transplant now with it being much a safer procedure. And then also being able to delay it by, let's say, a year if someone's getting treatment up front, they may be eligible to then, whereas, and that was another point that a lot of this retrospective looks have shown, that maybe up front the patient wasn't eligible because it was too risky for them. But a year later, when their disease was partially treated or very well treated, they were eligible. So I think, more to come, but I don't know that we'll have a lot more data in the near future on this.
Thank you. Before we go on to the subject of CAR T, we have a few questions we want to get answered. So, and if for some reason, everyone out there, if you feel your question wasn't answered or you have a new question, email it to Muriel@amyloidosissupport.org and I'll forward it to the appropriate panel member and we'll get your answer. Okay, now, this person wants to know, does Dara and the class of drugs cause fatigue? Dr. Lentzsch.
We don't know. I would say yes, absolutely. Dara can cause fatigue. But I think it's most likely what you get around the Dara. You get some Tylenol with the infusion. You might get some steroids to decrease the cytokine release or infusion-related reactions. So it's not quite clear. I see the fatigue, but it's not that profound. It's manageable, usually.
Do some of them get Benadryl as well? Because that can make you sleepy.
Yeah.
Okay.
I think that's an hour set, yeah.
Okay. Okay, we already gave update on the clinical trial. Calum, we don't have any results of the Calum trial, so we can't give you the results yet, but as soon as we have them, we'll share. Okay, my first bone marrow biopsy revealed a low level of amyloid. Do bone marrow biopsies reveal levels of amyloid? I think, okay, but my second biopsy did not reveal amyloid. Is that unusual? I'm confused. I thought bone marrow biopsies, revealed somewhat semi-accurately the percentage of plasma cells, and they can also reveal if amyloid is present, but not always.
So I can comment on this,
Sure.
And I think it's so historically, about 50% of patients, we were able to see their amyloid on the bone marrow biopsy. And usually you see it in the blood vessels. And it is, sometimes it can look more minutely, and, most pathologists will say amyloid present, when they do the Congo red, but, we know that the processing of the bone marrow, we may lose some of that data. So more recently, it's been suggested that we may have been able to see amyloid in more patients' bone marrow biopsies, for instance, with decalcification and just the way the bone marrow is actually processed versus some of the other tissue. So we don't, treat based on having the small amounts of amyloid or larger amounts in the blood vessels in the bone marrow versus not. That wouldn't really change your treatment. You theoretically, usually you're going to see amyloid in another place, whether it's the fat pad aspirate, your soft tissue, or your kidney. Rarely someone incidentally, you weren't even expecting it, and they don't have any organ disease, and you find, amyloid on their bone marrow. And we do classify those patients as having systemic amyloid because we see amyloid, but that's not that common a scenario. So not that it doesn't matter, but, theoretically, I would say most patients should have, it's in their blood vessels. They should have it with the right specimen and the right processing, but I don't think it's as, after treatment, a lot of times you won't see amyloid there anymore. So it's nice to see that before, after, but, I don't think it's the largest point to focus on.
Super. Any other comments before we go on? No? Okay.
Yeah, I would just say that in general, sort of amyloid in tissue from biopsies and looked at histologically is not a quantitative, we can't be quantitative about it.
Right. They either have it or they don't, right?
Well, but even if they don't, it may be a sampling issue. So
Right.
if you do it, yeah, I think it's not that helpful in terms of assessing response to treatment or severity of disease or something like that.
Okay, okay, let's go on to CAR T because we hear a lot about it and it was approved in multiple myeloma. And I'm like every other lay person when it comes to CAR T. I remember when it was first used in lymphomas, and I remember the big deal being made about neurotoxicities and how long people had, like 1 month in the hospital and all these other things. And I thought, oh, that will never come down to amyloidosis because of the expense. And they have enough neurotoxicity with amyloidosis without facing more from treatment, but obviously I'm wrong. So let's start with Dr. Landau. Dr. Landau, what's happening with AL amyloidosis and CAR T? Do you see that happening in trials?
So I would say that first we have to say that we do have our first drug approved for multiple myeloma, CAR T cell approved, Abecma, which is the BB2121 from BMS. And although it is effective in advanced multiple myeloma, the durability of response has, and actually, although there's CRS and although there's neurotoxicity, I think that overall in a very advanced myeloma patient population where this was originally studied, we can get them through these toxicities just like we can get the patients through a stem cell transplant, and patients who were very advanced have had good responses. Although I think that we're a little bit disappointed in the durability of the response, although in multiple myeloma where patients typically have continuous treatment, it's a really nice break for patients to be off of therapy after CAR T cells.
Is the durability longer than a year?
The durability is about a year overall and higher than that in patients who achieve a complete hematologic response. And there's other products, the Janssen product, the durability seems to be a little bit better. It's really hard. None of these are cross-trial comparisons. These drugs are effective. They're effective. There's an initial investment in, being in the hospital, being close to the center that's delivering these therapies. And then, recovery, like there's cytopenias and things like that. So it's not a cakewalk, but it's an investment in patients with advanced disease and can have a good response and then be off therapy for quite some time. If the issue is that even though this drug was approved in the spring, it's not widely available based on manufacturing and the actual rollout from BMS, which has the only approved drug, has been a little bit disappointing, I would say. Because of the capacity to manufacture, you have to collect the lymphocytes from the patient and then they have to manufacture these CAR T cells. And their capacity has been a little disappointing. If another drug, if the Janssen product gets approved, hopefully they'll have a better rollout. Regardless, in amyloid patients, it has to be studied just like any other drug. Again, we can't just treat amyloid patients like they have multiple myeloma just because they have a plasma cell disorder. Again, patients with amyloid have different end organ damage, which often dictate the toxicity that patients will experience to any of these drugs. I mean, there's a handful of patients. Most of our myeloma patients tolerate Revlimid like water or candy, and our amyloid patients have distinct toxicity to Revlimid. So I think that the trials have to be done in this patient population.
That was great. Thank you. Anyone want to add anything to that? So when do you think we might see some clinical trials for CAR T and AL amyloidosis?
Not in the near future, Muriel. No, that's the toxicity is too high, and I think we really have to find a sweet spot for multiple myeloma, and a safe CAR T trial before we can use it in amyloidosis. What I would see is more the BiTEs, the bispecific antibodies, or the drug conjugated antibodies, something like Blenrep, for instance, which is a monoclonal antibody that binds the plasma cell and has a toxic agent attached. There's actually a clinical trial open from Sorrento with a drug conjugated BCMA antibody, CD38 antibody. So those things will come into my amyloidosis, but CAR T cells, I don't think in the near future.
Okay, I know that everyone watching this wants to let us know how wonderful our panel was today. I know I'm kind of high. If I were flying, I wouldn't need a plane right now. So definitely fill out the survey that when you leave the webinar. And I just want to thank all of our wonderful doctors, our great team, and hopefully we'll be seeing you live one day soon. But until then, thank you, and we'll be calling on you again.
Thanks, Muriel. You do such a great job.
Bye. Thank you. Thank you. Have a nice weekend.
Bye.
Bye, everybody.
Yes, thank you.
Bye. Thank you.
Thank you, ladies.